Good evening, sir. Sir, very good evening. Good evening, all. We will be starting a program in a while.
Anita, your voice is echoing actually. And we have Dr. Garimana.
Yes, ma'am. Ma'am has joined.
Good evening, sir.
Good evening, sir. Good evening, sir.
Can we start the organizers?
Just a moment, sir.
Okay.
Good evening, Soumya, sir. Good evening, Raghunath, sir.
Good
Sir,
evening.
I'll be introducing you first, sir. I'll introduce you first, sir. Then you can take over. That's fine.
Yeah, no problem. Good evening, Dr. Biswas.
Thank you, sir. Good evening, sir.
Hi.
So you are back to Hyderabad, sir?
Yeah, I'm back in Hyderabad, Dr. Biswas.
Sir. Garima, are you good to go?
Yeah.
Yes, sir. Yes, sir. Good evening, sir.
Soumya, are you good to go?
Yes, sir.
Anita,
Yes, sir. Yes, sir. We can.
please. Garima, you can start.
Sir. A very good evening, everybody. I am Dr. Garima Saraugi, MCH Surgical Oncologist from Bhubaneswar. First of all, thank you so much, Dr. Ghanshyam Biswas, sir, and IAO team for giving me this opportunity. Let me welcome to you the program director for today, Dr. Soumya Surat Panda, sir. He is a medical oncologist from Bhubaneswar. Our organizing secretary, Dr. Dilip Kar, the scientific chairperson, Dr. M.V. Chandrakanta, sir, who is a medical oncologist. So first, Dr. Soumya Surat Panda, sir, will be talking about the introduction and context setting for today's webinar. Sir, over to you.
Yeah, thank you, Garima. So we have a very, very important topic today on the head and neck cancer, and the other one is the gynecology cancer. And we'll be hearing from all the eminent speakers, and we have chosen head and neck cancer screening, and the total program was designed and crafted by Dr. Dilip Kar and Dr. Chandrakant, M.B. Chandrakant. So they helped us in crafting this program, and we'll be hearing on the head and neck cancer screening. Then we'll be hearing the means non-ever-ending debate of IO, immuno-oncology and versus anti-EGFR in head and neck cancer. Then whether the IO has moved into a early resectable head and neck cancer. And then also we'll have here a good panel discussion on the local advanced head and neck cancer. And after completing the head and neck cancer, we'll move to the gynec. So we'll hear the rare gynecologic cancers, the endometrial cancer, where a lot of changes has been there. And then we'll also hear about the PARP inhibitors, and then we'll hear about also the HIPEC. And there are also a very nice debate on the cervical cancer screening. So whether it is hope or hype. So exciting evening forward. And with this, I will hand it back to the organizers to introduce our eminent speaker for the evening today. Back to the organizers.
A very good evening. So we'll start with the quiz first.
Yeah, so somebody should allow me.
So I will invite Dr. Ghanshyam Biswas, sir, for the first quiz on head and neck squamous cell carcinoma. Over to you, sir.
Please allow me. Again, today there is same problem.
Anita, you have to allow, sir.
Yes, yes, yes. I'm doing it right away, ma'am.
You should do it, no? So
Yeah. Sir, can you try sharing now, sir, please?
hope is seen, no?
Yes,
Yeah.
sir. Yes, sir.
We can see you.
So you can put the timer also. So this will be a 5 questions. So each questions will have either a pictorial or a 4 choices. So you have to put the right answer. So if you find A is the right, so write A in the chat box. And our volunteers will note down. So first come, first serve basis.
Sir, the quiz timer is ended. Embedded in the PPT. Is it fine if I share from my end, sir?
Please go ahead then.
Yeah,
Do it.
yeah.
Do it. Right. So the first question is, which is most common? A is lip oral cavity in terms of incidence in India. Second, B is larynx. C is naropharynx. D is oropharynx. So your time starts now. So you have to mention A, B, C, or D. So no answer in the chat box. All right. First answer. Please mention in the chat box, please. Time is up.
After 4 seconds, the timer is off.
Okay.
The
So,
time is up, sir.
right. So go to the next slide. So the answer is actually lip oral cavity, which is around 40%, followed by larynx, then nasopharynx, and then oropharynx, hypopharynx, followed by salivary glands. So the correct answer is A. So go to the next question. So comparison of extreme versus a TP extreme. So you have A, B, C, D. So in terms of convenience, extreme is 4-day infusion, TP extreme is single day. Grade 4 adverse events, 46% in the extreme, 33% in the TP extreme. Chemotherapy exposure, 6 cycles in the extreme and TP extreme, 4 cycles. So maintenance in extreme is weekly cetuximab, and even in the TP extreme is weekly cetuximab. So you have to find it out which one is wrong. So A, B, C, D. So your time starts now. So you have to find the wrong answer. So which is wrong? So out of these 4, so 3 are correct. I think many right answers are there in this time. Absolutely. Go to the next slide. So D is the right answer. You can see. So in the extreme, the maintenance is weekly cetuximab. In the TP extreme, it is bi-weekly cetuximab. Rest were right. Go to the third. So now these are broad indications in head and neck squamous cell cancers for cetuximab, anti-GFR. Indicated in combination with RT for initial treatment of locally advanced. Indicated in combination with platinum-based therapy with 5-FU and for first-line treatment of patients with recurrent metastatic like the extreme. Indicated as monotherapy in patients with recurrent metastatic for whom prior platinum-based therapy failed. Fourth is all of the above. So you have to find which is the correct answer. Your time starts now. So you have to find the right answer. A, B, C, or D. So last 2 seconds. Time's up. Go to the next slide. So the answer is all are correct. So all the 3 A, B, C are indications for cetuximab. So the D is the right answer for the volunteers to just hear. Next, 4th question. Hyperprogressive disease. So we know that Keytruda and nivolumab has made its own place in recurrent head and neck cancers, and we need to do something called CPS in regards to PD-L1. So hyperprogressive is one of the one we see in many cancers. So we are talking about hyperprogressive disease is seen in metastatic head and neck squamous cell cancer with immunotherapy initiation. What is the percentage? Less than 10%, 10 to 15, more than 15, and more than 20. So which one is the right? So time starts now. So hyperprogressive actually is a bad. So with this, if somebody has a hyperprogression, then there is a definite decrease in PFS and OS. So these are the patients probably will again go back to chemotherapy. So time's up. So go to the next slide. So the C was the right answer. Hyperprogressive disease was observed in around 15.4% in a recurrent metastatic squamous cell head and neck cancer patients, and it was associated with a worse overall survival and a PFS. Next. So the last question. So everybody of you know this gentleman. So identify the person and his cancer. And if you can add in which year he suffered. So Antara has written Sharad Pawar, so but we need both the answers. So person and his cancer. So somebody who mentions both together, then they will get the prize. So time's up. Do you know this gentleman next? So this gentleman is now 80 plus. He's very much active in the politics. Next slide. So he got diagnosed with head and neck cancers, the right oral cavity cancers. He was a tobacco chewer. So after his cancer, he also went for the tobacco de-addictions. So he's now 83 years. So he got the first disease in 2004. And our own teacher, Dr. Sultan Pradhan, was the primary surgeon. So that's the end of the first quiz 1 of day 2. So over to Dr. Garima. Dr. Garima,
Sir.
you seems lost.
No, sir. I'm here only.
What are you waiting for? You go to the next session.
Sir. Sir, the winners will be announced later.
Obviously. So, like yesterday only, no?
Yeah. So our next session is by Dr. Raghunath Rao, sir, who's a medical oncologist from Hyderabad. Right now he's in Hyderabad from Visakhapatnam. Sir will be talking about head and neck cancer screening strategies. Over to you, sir.
Good evening. Thank you, everyone. Thank you, Dr. Biswas. My brief today will be to talk to you about. You have removed me again. I've already shared my screen.
You can share it, sir.
Yeah. On screening for oral cancers. We can't screen for all the head and neck cancers, but I can let you know what we can screen and what is screenable. So you already heard from the question number 1 of the quiz that lip and oral cavity cancers form the highest number of cancers in head and neck cancers. And we know that 90% of oral cancers are squamous cell carcinomas. Unfortunately, 2/3 occur in the developing countries, South America, South Africa, Southeast Asia, and half of which are in South Asia. That is where India is. India alone accounts for roughly about 1 lakh incident cases annually. Peculiarly, the rates for men are twice as high as for women. There are some exceptions. Male to female ratio in Taiwan is 10:1. So very high incidence as compared to women. And apart from Cuba, India, Papua New Guinea is estimated to have the highest oral cancer incidence in the world, all of which is areca nut and tobacco chewing. Now, the last statement of this prelude is important. Early stage cancers are often asymptomatic. They mimic benign conditions, and they reduce the likelihood of a person seeking medical help. And therefore, screening provides an opportunity for early detection. This is the cardinal principle of what is called screening. So it should be identification of unrecognized disease. So if I say there is a lump in there is an ulcer in my mouth, or there is cauliflower-like growth in my jaw, or my cheek, or palate, that doesn't qualify as screening. So you need to recognize it through the application of a test, and the person to whom you have applied this test must be asymptomatic. And in order to identify those who are probably have the disease and to distinguish them from those who probably do not have. This otherwise is called specificity and sensitivity. So it should be in asymptomatic people with an unrecognized disease. What are the benefits of a screening program, especially in head and neck cancer? It can both downstage the disease and achieve a reduction in mortality and morbidity. I will talk a little bit about this mortality and morbidity a little later, but essentially you want to catch it before it gets anywhere. So in the case of oral cancer, in which majority have a pre-malignant phase, I said majority, need not necessarily. Screening criteria are designed to capture patients with oral cancer or oral potentially malignant disorders. They are called OPMDs, which are a group of disorders with an increased risk for oral cancer like leukoplakia, erythroplakia, etc., or pemphigus vulgaris, etc. So they are oral potentially malignant disorders. This is the important part. And of course, you can also capture patients who have something which is akin to an oral cancer. Identification and inspection is the typical way. So you feel, you see. Two important things. You feel between your thumb and forefinger, and you see with a well illuminated oral cavity. So all that you need is good light, and of course a sense of having felt something which looks like velvet, having felt something which is firm, which is with a raised everted edge, or with is not, you are unable to rub it off. So it's a systematic visual inspection and palpation of the oral cavity under a bright light source to detect abnormal oral findings that raise the index of suspicion for oral cancer or OPMD. I will show you the chart which we typically use. You don't have to worry about it. Now, here is the caveat. This screening test is not intended, oral screening test is not intended to be diagnostic, but it aims to capture patients with an abnormal oral finding, and so that it accelerates a referral and application of a more specific diagnostic procedure. Ultimately, it means that you require a biopsy to confirm. So this screening test is purely to help you refer a patient for a confirmatory test, which is a biopsy. Organized oral screening camps have several essential elements in case you are interested in organizing a oral screening camp program. One, you require a high attendance rate. You require good calibration of screeners. That means you need to train them very well to recognize what is normal, what is abnormal. You need to apply a quality control or a benchmark. For the applied test, whatever test you are choosing, I will show you what test you can choose other than visual inspection of oral cavity. And the availability, you must have a referral pathway to trace back for detected cases to receive adequate treatment. There are many screening models which have been used around the world, starting from Cuba, which did the first oral screening, oral cavity screening for cancer. They are called population-based screening, door to door, house to house, or by invitation. Opportunity screening, when somebody goes to a dentist for some dental abnormality or a pain. Integrated oral cancer screening with general health screening. That means just like how you check for your blood sugar and blood pressure, or an ECG and a urine examination, or a hemoglobin test, you must examine the oral cavity. Screening at place of work, like industrial sites, like industrial health or occupational health. Self-screening, yes, it is possible. Risk-based models identify and screening people with high-risk behavior. This is, of course, very cost-effective. Instead of a population-based screening, you screen people who are tobacco users or tobacco plus alcohol users. Now, this is a paper by Pindborg, the oral pathologist of repute. And this happened exactly where the Homi Baba Cancer Hospital in Visakhapatnam was created in Aganampudi. It was a rural health center in Aganampudi, where Professor Ramulu, along with Dr. Prakash Gupta and Dr. Mehta, Pindborg actually visited this site to identify reverse chutta smoking. So this is a type of oral cancer which occurs in the palate, in very young women, and the survival is phenomenally poor. So it is something very strange to only the north coastal Andhra Pradesh, that is Visakhapatnam, Vijayanagaram, Srikakulam, and East Godavari district. So typically for training and for identification, this is a WHO chart which can tell you what is the lesion to be identified, how do you identify it, and how do you do a referral. So don't worry about what it is, but anyway, it helps you detect an oral pre-invasive cancer. So if for your campaign to be successful, you need a good social marketing campaign. You need to increase the compliance, develop toolkits and e-learning modules to train screeners. National practice-based network should be established for data collection and future research. That means if you have all your dentists in a city participating in it, you need to have some data collection and to be there. So some documentation of XYZ has seen, and this is the second time this patient is coming for screening in 2 years or 3 years or 4 years, and develop a risk prediction model for primary care to assess risk profiles. Use mobile screening units that can travel from village to village, since it is to take the screening program into the village, not ask them to come to a primary health center. To increase the yield, integrate with screening for tobacco and alcohol related disorders, because these are the ones which typically predispose to an increased risk of screening. There is only one randomized control trial in the whole world from Kerala, 1994 to 2009. The intent of the trial was phenomenally important. It was to reduce mortality among screened population, which is the critical endpoint to assess the impact of any screening study. So this is the way you need to assess an impact. Over a 15-year period, there were 4 rounds of screening. Overall, totally 87,655 people, 91% of the target population was screened at least once. After 3 rounds, a 34% reduction in oral cancer mortality in the high-risk group of tobacco and alcohol users. After 4 rounds of screening, a sustained reduction in mortality at 81%, phenomenal, and further a 38% reduction in the incidence of oral cancer. Not just the mortality, but the incidence of oral cancer in the screened population compared to the control population. That means you need to combine the screening program in high-risk populations with a tobacco alcohol cessation clinic. This is important. So their report highlights the life-saving benefits of a program to high-risk subjects detected with oral cancers or OPMDs, and far outweighed any potential harm to those subjects who were screened and rescreened as negative. I wish to spend few minutes on this. There are 4 different varieties of oral cancer. One is called the aggressive, second is the less aggressive, third is the indolent, and the fourth is non-progressive. All of which will manifest as cancer at some time point, and depending upon the time you screen 1, screen 2, screen 3, or screen 4, we understand that the aggressive will never be helping. So they will progress between screen 1 and screen 2. So it is unlikely that any screening program will help them. Patients with slower growing oral squamous carcinoma lesions have a longer potential screening window and are more likely to be detected when they are asymptomatic. That means the less aggressive and the indolent will actually be benefited. As a result, a higher proportion of slower growing oral squamous cell carcinomas is found in the screen group, but it causes an apparent improvement in survival. But it is only an apparent improvement because the aggressive group is never helped by the screening program, and they continue to die from the oral screening program. This chart, you can keep it in your mind, actually applies wherever you are using a screening program, that some tumors will be aggressive, less aggressive, indolent, and non-progressive within that given tumor. It could be breast, it could be cervix, it could be rectum, it could be prostate, doesn't make any difference. In a different form of projecting the same thing, the less aggressive are detected earlier by screening, but this has no impact on survival and represents only a lead time bias. The previous one is called a length time bias. This is called a lead time bias, an illusion that those who are screened live longer with the cancer. So it depends upon when you picked up.
Sorry to interrupt, sir. 1 minute, 30 seconds left.
Yeah. when you picked up the cancer, nothing more than that. So sensitivity and specificity of visual oral examination is phenomenally high. There's a Cochrane review, systematic review, test the accuracy. 10 screening studies found a similar variability in sensitivity. So it is not a very sensitive test, but consistently very high specificity of 0.8 or 80% specificity. So these are the countries which have used visual oral examination, numbers of patients who have screened. I have given the specificity as 0.81, 0.98 in India, and the lowest figure which is reported is from Japan, 0.64. So fairly good specificity in terms of picking up the oral lesion. There are some current and emerging adjunctive techniques. One is called the optical based adjunct from BRC, or it was funded by DBT as a project, which is called tissue autofluorescence devices. There is vital staining or rinsing with the toluidine blue. You just ask the patient to rinse their mouth and the lesion stands out, something like visual inspection with aceto white or visual inspection with iodine, like what we do in cervix. Here you use toluidine blue. And of course, several cytopathological platforms. They are non-invasive and point of care, but none of these technologies have been validated in prospective large studies. So this is important. And of course, there's an additional cost of what you are going to use to do the test. Saliviomics is a new branch where an array of potential biomarkers based on salivary genomics, epigenomics, proteomics, etc., or transcriptomics and metabolomics, and including microbiomics, reflect that there is an impending oral cancer. So it's a saliva test on the saliva and is useful for a self-administered home screen test. You spit it to a test tube or it an open mouth or wide mouth bottle, cap it and post it to see what has
Sir, the
happened.
time is up, sir.
Okay. So these are
Sorry,
called
sir.
the point of care salivary diagnostic platforms. But none of these platforms have ever been approved by the US FDA. There are some adjunctive tests currently. So these adjunctive tests, there are not yet prospectively tested in oral cancer screening. In any primary care, they have been done only as a research protocol. So if you are using primary healthcare worker, that the best method would be to train them on whatever method you are using with good degree of accuracy, like trained dental practitioners. So you can still achieve the impossible if you know how to equip them with reliable systems to track the patient data. And you can use AI or mobile phone technology as well. Thank you very much for your patient hearing.
So thank you so much, sir. It was a wonderful talk, sir. Very informative for everybody. Sir, because of some issues, the debate is postponed to later session. Our next talk will be by Dr. Rupak Kumar Giri. He is medical oncologist from Bhubaneswar. He will talk about molecular landscapes in head and neck cancers. Dr. Rupak, over to you.
Yeah, thank you, Dr. Garima. So, can I see the slides?
Oh, yes, sir.
Okay.
Anita, please share the slides.
Okay, good afternoon to all. I'll be talking about molecular landscape in head and neck cancer. Actually, I was informed about this webinar today morning only. So there may be some glitches. I am not very much prepared for it. Anyways, I am Dr. Rupak Kumar Giri. I am working as a consultant medical oncology at Bakshi Sri Shankar Cancer Hospital, Bhubaneswar. So next slide, please. The learning objectives are management of incurable squamous cell carcinoma of the head and neck, and indications for chemotherapy, targeted therapies, and anti-PD-1 therapies. Okay, next slide. So this is just a flowchart representing what happens when a head and neck cancer patient will have a recurrent disease, or the patients who present with metastatic disease not amenable for curative treatment in upfront basis. So once the recurrent disease happens, the diagnosis is always by biopsy, and other staging evaluations are also done. And obviously, maybe HPV status may be looked into, especially when the origin is from oropharynx. Otherwise, other sites probably don't have much prognostic or predictive data for HPV. If the disease is amenable to curative treatment, then we'll go for surgeries and or irradiation based on the tumor board discussion or local surface surgery, whatever. If it is not possible, we go for medical therapy, and based on various factors like symptoms, disease burden, comorbidities, performance status, prognosis, patient wish, everything. Next slide, please. So the various treatment modalities when any local therapy is not possible for a recurrent or metastatic head and neck cancer can be broadly divided into chemotherapy, molecular targeted therapies, and immunotherapy. Next slide, please. So coming to chemotherapy, when used as a single agent, the response rates are probably highest among with the platinums, especially cisplatin and carboplatin, which ranges between around 20 to 40%. With oxaliplatin, it is quite less, that is 10%. Among taxanes also, response rate is around 20 to 40%. Then comes the antimetabolites, where we have data for 5-FU, capacitabine, and methotrexate, and their response rate hovers around something around 5 to 15%. Next slide. So the chemotherapy take-home messages for head and neck cancer cases is like median survival in patients is around 6 to 8 months. No evidence that chemotherapy prolongs survival. Polychemotherapy versus monotherapy, only the response rate is high, but there is no improvement in survival, and obviously toxicity is added. The drugs are the combination drugs. The various combinations of these drugs are used. That is cisplatin 5-FU or cisplatin, carboplatin, paclitaxel, or methotrexate. Next slide, please. Next, we will go into the molecular biology and targeted therapies. So next slide. So the molecular biology of head and neck cancers, head and neck squamous cell carcinomas, depends on whether it is an HPV negative tumor or HPV positive tumor. The HPV negative tumors are used to have a high amount of p53 mutations, that is mutated in about 70% of patients. Also, there will be p16 inactivation in around 90% patients, amplification of cyclin D1 in 30% patients. So other than that, we will also find other gene amplifications like EGFR amplification, FGFR amplification, and mutations in HRAS gene and other like PI3K pathway genes and all that. Then next slide. This depicts the various mutations what we see, like the genes associated with the cell cycle like CDK and 2A. That is, we see around 22% cases. P53 mutation is very high, 72%. Then CCND1 is very less. Then growth signal like EGFR alterations, then mutations is 4%. P3CA mutations are found in 18% cases, P10 3%, and WNT signaling pathway, the mutation rate is around 20%. Epigenetic regulated genes, there also 12 to 15% mutations are seen. Next slide. Then comes the HPV positive tumor, where the HPV basically have two types of proteins, the E proteins and L proteins. The E proteins are the non-structural proteins which take part in the DNA replication of HPV, and the L proteins are capsid proteins. They are structural proteins. Among the E proteins, we have E2, E1 to E7. Out of them, the E6 and E7 are the important ones. First, HPV gets bound to the host cell DNA through the E1 and E2. Then via E6 and then E6 and E7 expression increases. The E6, what it does, it degrades the P53. The P53 will be degraded, and E7 degrades the RB protein. So in HPV positive tumors, we won't find much of P53 mutation because P53 gets degraded. So the chief driving factor, this E6, after the P53 and RB degradation, the regulation on the cell cycle pathway goes down, and then there will be upregulation of the cell replication and the tumor formation. So here the E6 and E7 protein plays the chief role in pathogenesis of HPV positive tumors. Next slide. And how we detect the HPV infection? The gold standard test is to via the detection of E6, E7 mRNA by doing a PCR. And what we can do on day-to-day basis is looking for another marker, that is P16, which is upregulated in almost 90% of cases, and we can detect it via IHC. So IHC is the commonly used, and still if the patient is having negative in IHC and there is high clinical pathological suspicion that the patient will be having HPV positive tumor, so we can go ahead with HPV PCR DNA test. So, but commonly we use the P16 positivity by IHC. Since if there is actually some implication in the treatment and there is high clinical suspicion, then we can go for this HPV PCR for DNA detection. Next slide. So definitely the HPV positive tumors, as all of us may be knowing, that HPV positive tumors do well. These are the analysis from these landmark trials, where the clear separation of the Kaplan-Meier curves are seen with the good prognosis with HPV positive tumors compared to HPV negative tumors. Next slide. Same thing, even this is for P16 positive status. This is which is a corroborative marker for HPV positivity, and we can see that there is clear separation of Kaplan-Meier curves. Next slide. Same thing. Next slide. Next slide, please. Next slide. So this is already what I have discussed, how this HPV, how HPV drives tumorigenesis. So basically the E6 and E7 proteins of the HPV, they degrade the P53 and RB, and this leads to multiple mutations and tumor formation. Next slide. HPV detection of HPV is basically so far it is prognostic. There have been multiple trials to de-escalate treatment based on the HPV status, but not much breakthrough has happened. So it is still in the treatment part with respect to HPV. It is still under research. And there are many good signs have been seen, but so far prognostication is concerned. So we are seeing that HPV positive tumors are doing well compared to HPV negative tumors. Rest another molecular target which we can use in head and neck tumor is the EGFR targeting. So this can be done through these monoclonal antibodies like cetuximab, panitumumab, and jalutuzumab, and by tyrosine kinase inhibitors like gefitinib, erlotinib, or lapatinib, afatinib, dacomitinib, or others are there. Next slide.
So 5 minutes to go.
Acha, okay. Next slide. Next slide. Next slide. Next. Go to the extreme trial. Yes, this is the extreme trial where the 5FU plus platinum is compared with 5FU plus platinum plus cetuximab. You can go to the results, please. Survival results. So clearly, backslide. So here you can see there is a clear survival benefit of 10 months versus 7.4 months with a hazard ratio of 0.79. Next slide. This is the TP extreme study design where the 5FU cisplatin with cetuximab was compared with cisplatin, docetaxel, and cetuximab. Almost equivalence was seen. Next slide. You can see in the next slide. Almost equivalence is there. Next slide. The anti-EGFRs are failed in second line. These basically the gefitinib and these are the tyrosine kinase inhibitors. Not much good data when used in second lines. Next slide. Other genomic alterations which can be targeted are EGFR, HER2, HRAS, FGFR, PIK3CA, CCND1, homologous recombination deficiency. We have a trial recently published in JCO. Next slide. This is for PI3K inhibition, where bupralisib was tried with placebo. There are median survival was 10.4 versus 6.5 months. But the significance was just significance, not much impressive. Next slide. And another one is the tipifarnib, which is used in HRAS mutated cancers. Next slide, we have to see the data. So you can see the waterfall chart is looking very impressive here. Overall response rate 55%, median PFS 5.6 months, and OS is 14.5 months. Next slide. So next slide, this is the trial I was talking about, TRIUMPH trial. This TRIUMPH trial was published in JCO September 2023. So basically, it was an umbrella trial where alpelisib, poziotinib, nintedanib, abemaciclib, durvalumab are tried against this alpelisib for PIK3CA, poziotinib for EGFR, nintedanib FGFR, abemaciclib CDK4/6, durvalumab tremelimumab for anti-PD-1 and CTL inhibitor, where there was no mutation. So we can see next slide. We can see the response rate in alpelisib was 21%, poziotinib no response, nintedanib response rate 43%, and abemaciclib there was no response, and with durvalumab 15.6% response rate is there, and some good PFS was there, and all these patients were platinum refractory, and there was like in nintedanib we had 5.6 months of PFS. So some breakthrough has happened so far, like this trial, TRIUMPH trial. This is a basically Korean trial. Is showing some breakthrough. Maybe nintedanib and alpelisib, they can be taken up for phase 3 trials, and that will clear the things whether they are helping or not. These are all single arm trials, but these are single arm trials. Okay, next slide.
90 seconds to go, sir.
Okay, so next slide. So next slide is about immunotherapy. You can go to the directly that keynote trial. Please go ahead. Go ahead. These are the PD-L1 testing. We see the CPS here. Everyone will be knowing about CPS. So this is the keynote 048 study design, where extreme regimen was compared with pembrolizumab plus cisplatin or carboplatin 5-FU, and extreme regimen and was compared with this, and pembrolizumab single agent also was in this thing. Can please go ahead. So CPS was the one, not TPS, which was taken into account in this trial. Next slide. So you can see the difference where CPS more than 20. So we can see the pembrolizumab versus extreme arm. So pembrolizumab was showing a median survival of around 14.9 months versus extreme regimen of 10.8 months. And PD-L1 CPS more than 1. Again, pembrolizumab was showing 12.3 versus extreme 10.4. So next slide. So yes, this is the so median survival was 11.5 months and 10.7 months in the PD-L1. This PD-L1 more than 1% group. Next slide, please. Yes, pembrolizumab plus chemotherapy improves survival in CPS more than 1. Basically, the summary of this trial was, if the PD-L1 CPS is more than 20 and patient is asymptomatic, pembrolizumab is the drug of has shown the survival benefit over pembro plus chemo or extreme regimen, and that remains the drug of choice. If it is more than 1, pembrolizumab chemo versus cetuximab plus chemo, there is definitely survival benefit versus pembrolizumab plus chemo. So,
Time's up, sir.
next slide, please. So this is the summary, like rapid tumor shrinkage needed and CPS available. Then basically, if it is required, then we can go ahead with chemotherapy and chemotherapy plus if the CPS is available and CPS is 0, we will go with chemotherapy plus cetuximab. If CPS is available and it is more than 1, we'll go to the chemotherapy plus pembrolizumab. Okay, next slide.
Time's up, sir.
Okay, then that's all. Anything else? Next slide. Yeah, that's what I have already spoken about. So more than 20, if CPS is more than 20, we'll give single agent pembrolizumab. 1 to 20, not much. 1 to 20, it is pembrolizumab plus chemotherapy. Less than 1 or 0, it is chemotherapy plus cetuximab. But provided it is oral cavity origin, maybe chemotherapy plus cetuximab in frontline is helping more in many subgroup analysis that can be looked into. Okay.
Okay, thank you so much, Dr. Rupak. It was a very informative session. Thank you so much. Our
Thank you.
next talk is by Dr. Soumya Surat Panda sir. That is on management of chemo-induced nausea and vomiting and the role of Akenzo IV. Soumya sir, are you there?
Yeah,
Anita,
thank
please share the
you.
slides.
Thank you, Dr.
Thank you
Garima.
so much, sir.
Anita, can you share the slides for me?
Screen is visible, sir?
Yes. So thank you for sharing the screen. We had some wonderful discussions from Raghunath Rao sir, who is almost a teacher to all of us. And also I will thank Dr. Rupak. So having spoken in a very short notice, we told him today morning and then he took up the topic because of the absence of the another speaker. So thank you, Rupak. Now I'll move to the topic that has been given allotted to me, a new edge in the CINB management. So that is on the IV nitopitant. Next slide, please. So the flow of presentation will understand the CINB overview, then we'll go to the recommendations, then the mechanism and pharmacology, then what are the advantages and the evidence, and then we'll conclude the talk. Next slide. It is very important that we must recognize that the CINB adversely impacts the patient's quality of life. So patients, they are very much afraid when they have a nausea and vomiting to come for the second cycle. So it impacts the quality of life. So patients without CINB and patient experiencing CINB, you can see that patients who are experiencing CINB, they have a very bad quality of life. Next slide. So then another thing is that the perception versus reality. So what the doctors think and what the patient experience, that is a bit different. So we mostly underestimate the images with chemotherapy. So if we look at the patient's perspective, they do place it at a higher rank for the quality of life, especially the delayed nausea and the delayed vomiting. So that impacts the quality of life very much, and so that's why it is very important to control them. Next slide. So, and over the years, the efficacy in controlling the chemotherapy-induced emesis has progressed over the past 30 years. So you can see that from the 1980s to 90s to 2010, as the drugs have come up for the supportive care, the CINV is better controlled. Next slide. Next. Yeah, so you can see with the addition of the ondansetrons and the NK1 receptor antagonist, the delayed CINV is also protected as well as the acute CINV. So over the time, there is a better control of the CINV. Next slide. So the NK1 receptor antagonist, they are used in combination along with your 5-HT3 receptor antagonist, and they can control both the acute and the delayed CINV. So the delayed CINV is also well controlled. Next slide. Next slide. So coming to the guidelines, the benefit of adding an NK1 receptor antagonist, they are all evidence-based, and the evidence was based on 13 randomized clinical trials, and most commonly used drugs which can cause emesis was cisplatin and carboplatin and anthracycline and cyclophosphamide, which is mostly used in breast cancer. Next slide. So if you look at the recommendations, they're pretty uniform. That NK1 receptor antagonist is right up there in based on the ASCO guidelines as well as the MASC or the ESMO guidelines and the NCCN guidelines. So almost all the guidelines, they do recommend to use NK1 receptor antagonist, especially for highly metagenic chemotherapy drugs like adriamycin, cyclophosphamide, and carboplatin AUC5 and high dose cisplatin. So the NCCN that recommends for the moderately immunogenic chemotherapy potential patients, if there are additional risk factors like multiple vomiting episodes in the first cycle of chemotherapy, then you have to add the NK1 in the subsequent chemotherapy. Next slide. Next. Yeah, so this is the NEPA IV, which contains the phosphatidylpitant and as well as palinosetron. And when it comes to the phosphatidylpitant, so that is a next generation NK1 receptor antagonist, and it is a water soluble prodrug of netopitant. So netopitant is not water soluble, but if you add the phos part, then it becomes a phosphatidylpitant, which is water soluble, and it has got a high more than 90% receptor occupancy and long lasting, especially the brain receptor saturation is there after a single oral dose. And coming to palinosetron, again, it is got a high 5-HT3 receptor antagonist, and it results in long-lasting inhibition of the 5-HT3 receptor function. Next slide. So coming to the overview of IV netopitant, the dosage that was chosen was 235 milligram dosage. And since netropitant was not water soluble, so we made it fosnetropitant, which was IV formulation, and it is rapidly converted to the netropitant, and the dosage 230 milligram corresponds to a dose of 260 milligram of fosnetropitant chloride, and that has been shown to be equivalent to a oral netropitant dose of 300 milligrams. Next slide. Next slide. So this was a trial to look at the safety of the IV NEPA plus netropitant and dexamethasone combination. And the design of the trial was, it was a phase 3B trial, and the control arm was oral netropitant, and the patient population was female more than or equal to 18 years, who was diagnosed as breast cancer, and patients who were receiving a highly hematogenic chemotherapy drugs, and at least 4 cycles of atramycin and cyclosporine. Next slide. So this is the design of the trial. It was randomized into 1:1, and the IV netropitant was given on day 1 along with 12 milligram of dexamethasone and 8 milligram on day 2 and day 4. And the control arm, as I mentioned, was the oral netropitant. Next slide. So coming to the overview of adverse event. So that is the reason that this was the primary endpoint, the adverse event. And if you look at the serious or a severe treatment related adverse event, it was something like around 1 versus 1.5. So it was proven that it was almost at par with the oral netropitant. So the adverse event for the entire study period was very similar in the two treatment groups. Next slide. Coming to the local tolerability. So whether there is any infusion site reactions, which we had already from IV fosnetropitant. So whether IV fosnetropitant was having a local site reactions or not. If you look at the infusion site extravasation and the injection site extraction and reactions, it was very minimal, and the thrombophlebitis was also very minimal. So IV netropitant was unlike a IV fosnetropitant, where the local site reaction was very less. Next slide. Coming to the cardiac safety, again, this was a very important concern, because we knew that there was a QTC prolongation when it came to the apripitant, and there have been case reports and case studies where the QTC prolongation was documented. So IV NEPA compared to oral NEPA was very safe, and it did not show a kind of a alarming QTC prolongation. Next slide. Next slide. So the safety of the IV NEPA compared to the oral NEPA, and so this was the efficacy. So the earlier one, we studied mostly the tolerability and the safety part, looking at the overall tolerability, looking at the cardiac safety and the local reaction. And in this part, again, we look at the safety as well as the efficacy. So this was a randomized study of 404 patients, and stratification of the was done by region and the age, and there was a comparison for the IV NEPA compared to oral NEPA plus dexamethasone. Next slide. So baseline characteristics were well matched between the IV NEPA and the oral NEPA arm. Next slide. So the overall incidence and intensity of treatment emergent adverse event were similar between the two treatment groups in cycle 1 and throughout the study. So there was no serious treatment related adverse event associated with IV NEPA. So this was reassuring to almost all the clinicians that the IV NEPA was equally safe as we had seen with the oral netropitant. Next slide. So the similar incidence rates of treatment emergent adverse events were seen for both IV NEPA and the oral NEPA groups. Next slide. So the no infusion site or the hypersensitivity or anaphylaxis like adverse event were reported as the treatment related in either of the treatment group. Next slide. So when it comes to CINB trials, we must understand that there are endpoints like complete remission. And what do you mean by complete remission? Complete response. So CR is something like no emesis, no nausea, no rescue medications are required, and so the CR rates were very high both for the IV NEPA and the oral NEPA. It was something like 86.85% versus 88.6%, and in the delayed phase it was 78% versus 78%. So almost we could see that the IV NEPA was almost equally efficacious compared to oral NEPA. Next slide. So coming to the quality of life, the IV NEPA and oral NEPA were almost comparable. So nausea and vomiting and oral combined, if you look at the cycle 1 and the subsequent cycle 2, so the functional living index MSS were almost comparable, and it resulted in a good quality of life. Next. So again, this is a direct comparison. So earlier we had seen the comparison of a fosnetropitant versus a oral netropitant. So now we will see fosnetropitant versus fosaprepitant. This was based on the Japanese data in the highly metagenic setting. Next slide. This is a study of the study design. The patient with malignant tumors able to receive chemotherapy, including high dose cisplatin. And there was a part 1S. S means the single single administration, and M means multiple administration. So the S cycle that compared with the fosnitropin plus palazestrant plus dexa versus the fosnitropin plus palazestrant plus dexa, and part 2 was fosnitropin plus palazestrant plus dexa. Next slide. So the fosnitropin was infused separately from the palazestrant on the fosnitropin, palazestrant and dexa was mixed together. They were mixed and infused together, but fosfepridine was infused separately from palazestrant and dexa due to potential risk of incompatibility of fosfepridine with palazestrant. And then they were compared, fosnitropin versus the fosfepridine. Next slide. The result, CR was non-inferior to the fosfepridine. And in the you look at the CR rates, it is 75.2% with the fosnitropin versus based regimen versus 71% of the fosfepridine based regimen. Next slide. And if you look at the efficacy numerically, if you look, the fosnitropin was doing better than the fosfepridine. Next slide. So coming to the incidence of the injection site reactions, they were significantly lower with fosnitropin versus fosfepridine based regimen. It was like 11% versus 20.6%. And if you look at the serious adverse event, it was 0.3% versus 3.6%. So injection site reactions, including pain and the erythema, embolus and swelling, so they were less with the fosnitropin. Next slide. Next slide. So the CR rates, they were significantly higher with the fosnitropin versus the fosfepridine. So 73.5% versus 66.9%. Next slide. So it was not only that IV NEPA has got its dual antiemetic action, offers the additional convenience to healthcare practitioners. IV NEPA is bioequivalent with comparable safety and efficacy to oral NEPA, and the lipid formulation ensures that no reconstitution is required, easier to prepare and administer, and the efficacy in acute and delayed vomiting and nausea comparable to fosfepridine with significantly better CR, complete responses during the extended interval. So the better CR rates were there, and no hypersensitivity reaction and infusion site adverse events were noted when compared with the fosfepridine. So with that, I conclude my talk. Thank you. I hand it back to Dr. Garima.
Thank you so much, sir. It was a wonderful talk, very nicely summarized. So for our next session, we have role of immunotherapy in resectable head and neck cancers by Dr. Bharat Rangarajan from Coimbatore. Bharat sir, are you there? Dr. Bharat Rangarajan, do we have you? Anita, do we have sir?
Yes,
Can you
ma'am.
hear me? Can you hear me?
Yes, sir, you are audible, sir.
Yeah.
Very warm welcome, sir.
Yes, and is my screen shared? I have done the screen
Yes, sir.
sharing. Hello?
Yes, sir, your screen is visible.
No.
Anita,
Is
can
a
you please start
PowerPoint
it from the
visible?
slides?
Is a
Yeah.
PowerPoint visible?
Yes, sir.
Hello? Yeah. So can I start?
Yes, sir, please start.
Thank you, and thanks to Vishwas sir, my senior and my mentor and my good friend and my well-wisher. The topic allocated for me is role of immunotherapy in resectable head and neck cancer. A bit of a shocker, made me read data for this presentation specifically. So let me just start the. Is the slide moving? Hello? Hello?
Anita, next slide, please.
No, yeah. So,
You are not.
yes. Yeah. So, as far as resectable head and neck cancers are concerned, we are thinking of squamous cell carcinoma of the lip, oral cavity, and all the subsites of the oral cavity, including oral tongue. Hypopharynx and larynx tumors, which have cartilage erosion or larynx dysfunction, because others would go for chemoradiation. Thyroid, uncommon sites, and uncommon histologies, which I am not covering today because this is basically for head and neck squamous cell carcinomas, which are form the bulk of tumors. Role of neoadjuvant and induction chemotherapy has always been controversial, and it is used in highly selected cases. We are talking about borderline, we are talking about resectable. We do use it in borderline operable and inoperable cases whenever the surgeon needs a little bit of tumor response before attempting a surgery, what can be between T4A and T4B or large N3 nodes. But otherwise, it is debated, and role of immunotherapy is just evolving. What are the reasons for neoadjuvant immunotherapy? The reasons could be downstaging. The relevance of downstaging in an operable tumor is questionable, because this we are talking about resectable tumors. So what is the relevance of downstaging? Which is not sure. Pathologic responses. This may or may not happen. They may be surrogate markers. And then, of course, we always discuss the most important reason for giving neoadjuvant immunotherapy would be OS or DFS benefit. So what is the data looking like? What are the phase 2 trials evaluating immunotherapy? Let's start with nivolumab plus ipilimumab. This is a trial, oldest trial in this group, published in 2020 in JAMA. Schoenfield's trial evaluating nivolumab, neoadjuvant nivolumab or nivolumab plus ipilimumab in untreated oral cavity alone, oral cavity squamous cell carcinomas. Trial schema, there were 2 cohorts. One cohort received just 2 doses of nivolumab. Nivolumab was given at 3 milligram per kg on week 1 and week 3. And the other cohort received nivolumab, the same schedule, 3 milligram per kg week 1 and week 3, along with ipilimumab on day 1 alone at 1 milligram per kg, a small dose. And after 2 doses, the patient underwent restaging and surgery. And adjuvant therapy would be at the discretion of the physician, as required, whether there would be radiation or chemoradiation as per the path response. PD-L1 range in this trial was between 0 to 91%, and 20% of patients, that is nearly 8 patients, had less than 1% PD-L1. 30% were enrolled, and this is the cohort diagram and the baseline characteristics. So there were oral tongue, gingiva, retromolar trigone, alveolar ridge, buccal mucosa, hard palate. So predominantly oral cavity tumors. What was let's look at the path responses in the waterfall plot. There were good responses to both the Nivo plus IP arm or the Nivo alone arm, but more responses seem to be happening in the Nivo plus ipilimumab arm, where there were some complete responses also with just 2 doses of Nivo and 1 dose of EP. And the progression-free survival, 1 year PFS was 85% and 1 year OS was 89%, with 86% alive and disease-free at data cutoff. But remember, this is a trial with 29 odd patients, so very, very small trial. Now coming to pembrolizumab in resectable head and neck cancers. This trial is by far the largest trial in this subset, published in the annals of the AACR, the journal, the Clinical Cancer Research Journal, by Ravindra Uppaluri. And this trial also had 2 cohorts. The first cohort was pembrolizumab, just 1 dose, and surgery 2 to 3 weeks later after the single dose. And the adjuvant therapy was risk stratified based on the pathology. The cohort 2 had 2 doses of pembrolizumab with surgery and risk stratified adjuvant therapy. There was no maintenance pembrolizumab. It was proposed at first, but it was not given. All patients were HPV or P16 negative and newly diagnosed stage 3-4 resectable head and neck cancers, included other subsites also, larynx and hypopharynx. Now, the important thing here to look for is the pathologic tumor response. The pathological tumor response is not same as PCR or what we say pathologic complete response. Pathologic tumor response refers to the presence of tumor cell necrosis and keratinous debris and the residual tumor. So on a scale, PTR 0 means there was less than 10% necrosis. PTR 1 means 10 to 49% necrosis, and PTR 2 means more than 50% necrosis. So please remember this slide, because this is what would form the basis of the responses for the next few slides. So PTR 2, that is more than 50% necrosis. That is good response happened in 8 patients, 22%. PTR 1, that is 10 to 49% necrosis happened in 22. So 44% of patients had good response. That is more than 10% tumor necrosis, of which 22% patients had more than 50% necrosis. So overall, 44% had more than 10% necrosis. Now, when we look at the survivals, the cohort 1, that is one dose of nivolumab, when the PTR was 1 to 2, the relapse-free survival was 100%. Whereas PTR 0, that is less than 10%, the survival was around 60%. So very good, difference based on the necrosis. When we come to cohort 2 for 2 doses, this is the baseline characteristics for the cohort 2. There were 29%, 29 patients in cohort 2. Most of them oral cavity, very few larynx and hypopharynx. And cohort 2 had a PTR2 of around 42%, PTR0 of around 50%. So 50-50. 50% had more than 10% necrosis and 50% had less than 10% necrosis. And the high risk and low risk was classified based on positive margins and extranodal extension. 5% were high risk and 5 patients had high risk, that is 17%, and 23 patients, 82% were intermediate or low risk. Now, what happened to the comparison between cohort 1 and cohort 2, that is between 1 dose and 2 doses of pembrolizumab? The PTR2 rates increased from to 42% from 22%. So 20% more patients actually developed more than 50% necrosis when you gave 2 doses of pembrolizumab. What happened to the high risk patients? Cohort 1 had 50% high risk patients and cohort 2 had just 17% high risk patients. That is, margin positivity rates and ENE rates came down by nearly 30% when patients were given 2 doses of pembrolizumab compared to 1 dose of pembrolizumab. Downstaging of the tumor, pathologic downstaging of the tumor was also significantly higher in the cohort 2. That is, the patients who received 2 cycles of pembro. And the survival, of course, this is a very, very small study, but the survivals, the PFS probability and OS probability are above 90% with 2 doses of pembrolizumab. Now, passing on from this trial, what would happen if we give neoadjuvant followed by adjuvant pembrolizumab? This trial was published by Trisha Weiss-Draper in the same journal, the AACR, the Clinical Cancer Research Journal. This is the cohort diagram for this trial. Neoadjuvant pembrolizumab was started in 92% of patients, and based on the risk stratification, patients went on to receive either weekly cisplatin with RT for the high-risk patients, along with pembrolizumab 7 doses, or they went on to receive just RT and pembrolizumab 7 doses. So the patients who had negative margins and no ENE did not receive cisplatin, which conforms to standard of care today. The the 1-year DFS for all patients was around 80%, which is better than the published RTOG trials. The 1-year DFS for the intermediate risk group, that is 31 patients, that is no extranodal extension, no margin positivity. This group was 96% 1-year DFS, and 1-year DFS in the high risk was around 66%. So high risk patients continue to do worse, that is extranodal extension and margin positive. These patients continue to do worse than the patients who are intermediate or low risk. Now, survival based on pathologic response. So here it is stratified as into just 2 categories. That is, no pathological response or some degree of pathological response. That is either a major pathological response where there was more than 50% necrosis or 10 to 50% necrosis. Again, with this stratification also, the survival seems to be better with patients who have received pembrolizumab 2 doses, went on for surgery, and then continued based on whether they received cisplatin and RT based on risk stratification. But path response itself stratified towards better survival, both DFS and OS, in the patients who had some pathologic response versus no pathologic response. Taking this hypothesis forward, the keynote 689 is testing the same trial schema, that is pembro 2 cycles prior to surgery or versus neoadjuvant followed by surgery. This will be followed by either pembro 15 cycles along with RT plus cisplatin in the high risk or pembro plus RT alone in the low risk versus no adjuvant therapy versus standard adjuvant therapy, RT or RT versus cisplatin, which is a standard of care. This trial, of course, is awaiting publication. To summarize what I have spoken in the last 10 minutes, data on neoadjuvant immunotherapy is evolving, but definitely it looks exciting. Pathologic response to the tune of nearly 40% can be seen. That is, more than 50% necrosis can be seen with just 2 doses of immunotherapy. 1 dose of immunotherapy may give a path response of around 20%. That is, more than 22% of patients may have a major pathologic response of more than 50% necrosis. Patients with pathologic response have a survival advantage, DFS and OS. However, this is phase 2 data. This is not powered to look at survival benefit and may not be able to incorporate into practice with this response. Biomarkers, PDL1, others, we have to develop these biomarkers so that we can treat patients who have the best benefit from these sort of neoadjuvant and adjuvant immunotherapy strategy. The larger phase 3 trial, which is underway, the Keynote 689, will help us identify the real benefit or lack of benefit, but hopefully better benefit in this difficult. Please remember, even the RTOG is showing around 65 to 70% survival in the high risk, that is margin positive and the extranodal extension positive. So there is a long way to go to bridge for these patients, and this addition of immunotherapy, stratified and proper immunotherapy may be the way to go ahead. It was safe to use. I did not show the safety data because it is of 1 and 2 doses. There were actually no new safety signals, no delay in surgery or any adverse event that was very different from what the medical oncologists usually use, because we use much higher doses for 1 or 2 years. There were no new safety signals. Thank you very much.
Thank you so much, sir.
Yes.
Sir, 2 things, sir. I want to ask you. One is, sir, as such resectable head and neck cancers where we are not going for a neoadjuvant therapy, could this be considered applicable for that also?
As
Front
of now,
resectable cases?
no.
Yes.
As
No,
of
no,
now,
sir. No,
as of
under
now,
study also, sir.
No, as of now, I think that, we cannot be offering it to patients, because as of now, what we know is that it is safe. We know that there are pathologic responses. We know that surgery is not too delayed, because patients have gone to surgery within 4 weeks. If it's 2 doses of Nivo, they've gone to within 4 weeks, they've gone to surgery. Or if it's just 1 dose of Pembro, they've gone just 2 weeks after Pembro for surgery. And if it's for two cycles of Pembro, they've gone within 5 weeks of there is only a delay of 5 weeks. So there is no delay in surgery. There is good path response. But with this data, we cannot take it into practice as of now, because we are talking about resectable. My topic was specifically resectable.
Yes,
As of now,
resectable.
for resectable, it still remains, surgery remains a standard of care. But the Keynote 689 is going on. We may change practice based on that trial.
Sir, thank you, sir. And sir, my second doubt is the response in the trial that you showed was best in the intermediate risk group, but the high risk group was not,
Yes.
sir.
Yes.
So high risk still remains?
Yes, the intermediate and the low risk patients, that is patients who had a complete resection, no ENA and no margin positive. They were the one. But we know that, the ones with especially margin positives are going to do very badly.
Yes.
But that number is very low. If you look after 2 cycles, there were just around 17% of the patients who were remaining in high risk. So you are going to reduce the number of high-risk patients by giving 2 cycles. That is also the take-home, your number of high risks are coming down when you're giving neoadjuvant immunotherapy. So that is, your point is taken, but look at it from the other angle. You will have lesser number of high-risk patients if you use neoadjuvant. But it has to be proven in a randomized fashion.
In the Keynote 689, yes, sir.
Yes.
Thank you so much, sir. Wonderful session.
Thank
Good
you.
learning for all of us.
For me too.
Anybody else, because this is an interesting topic yet to be considered in practice. If anybody has a doubt, we can discuss with sir. Sir is available. So our next session today is, thank you so much, sir, for the wonderful session.
Yes, I'll stop sharing.
Yeah, sir. Our next session is a panel discussion on locally advanced head and neck cancer. It is by Dr. Arvind Krishnamurthy, sir. Sir, welcome, sir. So you were my examiner in my MCH.
Oh, nice to see you again.
A very warm welcome, sir. I'll give the panel to you, sir.
Sure.
Thank you so much.
Share my screen. You should allow me to share my screen. Yeah.
Yes, sir.
Doing it,
Anita,
sir.
please.
Yeah, doing it, sir.
Yeah, great.
Yeah.
Yeah. Am I seen and is my voice audible to all? Hello?
Yeah.
Yes, sir,
Am
you're
I audible?
audible, sir. Yes, sir, you're audible, sir.
Am I audible now? Yeah, great.
Yes,
I
yes.
think, yeah, thank you. I think I'm traveling, and I think I hope my signal sorts of stands up, So anyway, thank you for the opportunity, and I think I have got an esteemed panel, and I have a job to do on locally advanced. Moving 1 second. Stop share and reshare. Yeah. An esteemed panelists, I think it's a multidisciplinary team of 3 surgical oncologists, 2 radiation, and a couple of medical oncologists. So I think locally advanced head and neck cancers do require a multidisciplinary tumor board, a definite Indian problem. I just want to ask some of our panelists, maybe the surgeons in our panelists, Dilip can start. What do you understand by locally advanced cancer?
Dilip, sir, are you there?
Or anybody can take that for that matter.
Hello.
Yes,
Hello.
Dilip, I can hear you.
Yeah.
Please go
ahead. The only thing that the single line I can put my line T1N1 to T4B N3, and if you add for 8 HCC, any tumor, surface tumor more than 1 centimeter depth, that's considered local advance.
Great. Any other thoughts from any panelist? Shishir, if you're there,
Shishir.
Shishir, sir.
Or
Put
Dr.
Shishir into
Sunil,
in.
anybody can take that.
Sunil, sir.
Or Dr. Sunil, I can see you. You can
Hi.
sort of,
Hi, good evening. So anything beyond stage 3 is considered as locally advanced?
Right. Yeah, great. I think, in fact, there is no standard as such definition. But as was said, anything between more than stage 3 or stage 4, because sometimes, unlike any other cancers, even in head and neck cancer, stage 4 is also under the realm of cure, especially the stage 4A. So I think that would be locally advanced. I just wanted to understand that, do we have a consensus that all the locally advanced cancers are discussed in MDT?
Yes, definitely, sir.
Absolutely.
Yeah. Great. I think so. At least good that we have consensus that anything more than stage 3, and definitely it warrants a multidisciplinary tumor board. So I think just to sort of give things in a better perspective, I thought I'll just share a case scenario. A 72-year-old male, performance status 1, tobacco chewer, ulcer right lateral border of tongue, 2 months, 5 into 4 centimeters right lateral border of tongue, but is actually extending into the oropharynx as well. The patient had a right level 1B and 2 nodes, 3 into 2 centimeters. So I've got just this clear picture of the intraoral picture. This is the border of the tongue. It's a proliferative lesion, right lateral border of the tongue, and it is actually extending into the posterior 1/3 of the tongue. He had an outside CT scan, and it did show involvement of the oral cavity extending into the oropharynx, just up to the vallicula, and there was a level 2 lymph node was there. I just wanted to understand from anybody in the panel, how do we go about the further evaluation of this patient? I just want to sort of just to show this picture again. The unique sort of a scenario, a sort of a proliferative growth, if you see, from the right lateral border of the tongue extending into the posterior 1/3. And in the scans, you can clearly see that it is actually overlying the sort of vallicula as well. Like, so any thoughts as to how to go about this case? Anybody can, I don't want to take names. I thought anybody who is there can take it up. Like, if Shishir is there, he can, or I would ask our non-surgical panel surgeons also to sort of, chip in. Dr. Sheikh, Dr. Lucy, Dr. Gautam, anybody for that matter. Sunil, I can see you. I think you're
Yeah,
to
sir.
go.
So
Yeah,
I'll
go
do
ahead.
that. I think only the MRI was done, right, sir, beforehand?
Only the CT scan was done.
CT
This
scan
patient
was
had
done.
an outside CT scan.
Okay. So I'll definitely like to have an MRI to get the soft tissue detail. It's better in a case of a tongue. And the next step that I like to examine under anesthesia. So
wonderful. What? What about a CT scan of the chest or a PET CT?
If you go by recommendations, sir,
in real world practice?
If you go by recommendations, it will be wise enough to go for a PET CT scan, because NCCN already recommends anything beyond stage 3 node positive things. It's better to get a PET CT done to rule out other sites of metastasis. So we can get that done also. And I think that will be enough for us to have a DMG and get an opinion done.
Great. Any thoughts from anybody else? Like, any of our non-surgical colleagues can sort of, or Dilip, after you.
Yeah, I agree with Sunil. But if we see the study right now, the PET CT and CT scan has the detection rate of 2.8% versus 2.6%. PET CT, if in a economical restriction place, CT thorax is wise enough.
Great. Now, how is the general practice at Bhubaneswar or Cuttack? I just want to have the local flavor, since it's a topic emanating from there. So anybody can sort of give that perspective.
Yeah, Arvind, in our cases, it's a government setup and it's a private setup. The PET CT is free by the government schemes. So most of the patients and they're undergoing PET CT scan, and probably by that way, maybe our upstaging is more, and we are getting better result, and maybe some cases are avoided for surgery. A PET CT is free here in Odisha by government scheme.
Oh, okay, great. Any other points, Dr. Lal? You had a point to make.
Yes, sir. In advanced stage cancer, like stage 3 or stage 4, we may go for the scan to detect the pulmonary metastasis.
Right. No, I think great points. I think got to know that PET under the government schemes is free. I think it's a good thing. But in the interest of choosing wisely, I think Sunil did make a good point, and Dilip also made it, that in locally advanced cancers, I think especially in such cases where it is T4, and especially in cases where the nodal metastasis is slightly higher, then there is a chance of having more amount of distant metastasis. I think so. That is the reason that we tend to image the chest. I think chest imaging becomes mandatory. Beyond the chest, I think there are very, very few sub areas in which the cancer spread. So PET CT is maybe optional, but definitely it warrants a CT scan of the chest, if I must say so. Is it all okay with all the panelists? The points made, and can we move on?
Yes, sir.
Agreed.
Yeah. The biopsy was done. It was a squamous cell carcinoma grade 1, and I just wanted to understand the further management. Let me go into the case details again. So this is a large tumor involving the right lateral border of the tongue, but this time it's almost going into the vallicula. There are multiple nodes in the right level 1, 2. So it's basically, if you see the stage, it would be around a T4B, N2B. And in this case, of course, a PET was not done, just an MRI and a CT chest was done. So I just wanted to understand from our surgical colleagues, unresectable versus inoperable. Does this sort of, does this terminology hold good any longer, or how do we go about in practice in this?
Hi, Arvind. You can hear me?
Yeah, hi, Shishir. Hi, Shishir. Yes, yeah, we were just looking for you.
I was trying to get in line here.
Great,
So,
great.
very interesting, right? Because you've got a locally advanced disease. You've got a neck, technically a neck which is operable. But this disease which is there, there's no point in going ahead with a surgery where you're going to remove the tonsil, the palate,
right,
and you do not know the extension to the base of the tongue. It will be a very morbid surgery. So, technically, yeah, it is not inoperable. It can be operated, but then we got much better result with the neoadjuvant chemotherapy. So yeah, I think I would pass for this.
Okay. Yeah, great points, great point. And if you see, one of the criteria for neoadjuvant chemotherapy as was laid was tumor of the tongue extending into the vallicula. But I just wanted to ask our non-surgical colleagues, maybe Dr. Lucy, or our medical colleagues. Dr. Gautam, is there?
Yes, I'm good.
So, I just wanted to understand, Dr. Gautam, do you make the call for resectability, or do you sort of, do you send it to the surgical colleagues, and then only when they say unresectable, then does it come to you? How is it in your practice in general?
So, sir, every patient who comes to the hospital undergoes basically multidisciplinary management, whether it is stage 1 or whether it is stage 4. So, first he will be subjected to the multidisciplinary tumor board, basically, which consists of either surgery, radiation, and medical oncology both. If the tumor is basically deemed to be unresectable, he definitely goes for the either CTRT or palliative chemotherapy, depending on the fitness. If it is borderline resectable, then it goes for the NACT followed by reassessment. And if it is operable, straightforward, it goes for the surgery, provided there is some provision of NACT in mandibular preservation, but not in this case.
Oh, great. Oh, great. I think you made almost most of the points. The only thing in this scenario, what was there, was that although technically this is a sort of comes under the criteria of resectability, if you see the nature of the tumor, it is very, very proliferative. And the depth of invasion in this case only about was very less, around about 6 mm or so. So I think that was the thing that, and because of this proliferative component, we decided, okay, let's go for surgery for this gentleman. And we sort of, went about doing a surgery, compartmental resection. But as was said, I think we had to do a free flap, free ALT flap, and a modified radical neck dissection. This was the histopathology. Margins were clear, but there were extensive PNI and LVI. And 9 nodes actually were there, and without any perinodal extension. I just want my surgical colleagues to answer the issue with margin. Dr. Sunil or Dr. Dilip, anybody can take it.
So any margins more than 5 mm is considered as adequate. So we should usually aim for at least 1 centimeter while doing surgery.
Great. And Shishir, intraoperative frozen section, what is your take? Do you regularly use or selectively use? Or
no, I use it for all my cases in head and neck.
Okay, great.
So I had a small issue with the lymph node. There were only 9 lymph nodes. That was a little surprising.
9 were positive. I'm sorry.
Positive.
Okay. Yeah.
9 was positive or out of 30. Yeah. Sorry.
So I was just looking at it. Only 9 is a little less.
Yeah, great. Like, Dilip, what is your take on intraoperative frozen section?
Dilip.
Dilip, you're there, or if Dilip also is traveling,
I'll take on that. I'll take on
Yeah,
that.
sure.
Whenever
Great.
we are dealing with a locally advanced case, and if you have a frozen section backup, it's always wise to use that thing, because sometimes we will miss submucosal disease. And in the final histopath report, sometimes we may come quite close from the normal margins that we expect. So it's usually wise enough to use a frozen if we have that facility available with us.
Great, great. I think quite wonderful points made. With regards to margins, yes, I think you go about a centimeter or probably in tongue, little more, a centimeter and a half, possibly to achieve 5 millimeters of histological negative margins. Lot of data to suggest that margins lesser than 5 millimeters may be acceptable. I think there is a critical review earlier this year saying that a margin of around 4 to 4.9 mm may be reasonable. But having said that, most of us actually sort of do a margin of more than 5 millimeters, and the use of intraoperative frozen section. Yeah, go ahead, Shishir.
Arvind, in head and neck cancers, I suppose it's more of a local control, which is very important, because most of them are not metastatic disease. It's a local disease which comes back. So I think every effort has to be made for a clear margin, and if frozen is going to help you, then you should use it. This margin positivity is very dicey, because we see it quite a bit. Sometimes when you don't, even when you have margin negative, still you can get a disease recurrence, and it may be because of skip lesions which are seen, separate lesions which has not been there. But we do whatever we can do about it.
Right. No, I think points well taken. I think you made a very important point of having and achieving a negative margins. Positive margins is almost doomsday. The story is over. I just am presenting some sort of evidence to suggest that, of course, these are retrospective analysis. So most of the times in real world, we do go for 1 or 1.5 centimeters, and then subsequently histological margins negative. A frozen section, I think there is, in real world, I think most of us tend to use frozen section. But if you see the evidence actually doesn't really sort of support the use of frozen section in a great way. Although I must agree, like we also use it in our patients. We send our sort of the entire specimen to the histopathology. But then there is the dichotomy between what is the evidence and what is real world practice. Even a publication earlier in this year in JAMA actually said that the sensitivity of the intraoperative frozen section was just around 10%. And of course, specificity was very high, close to 99%. But having said that, I think, as I said, most of the times surgeons are comfortable for various reasons, medical, legal, or otherwise, document, tell the patient and the family if facilities are available. So that's the other point I needed to make. The other important question in this particular scenario is, what about the adjuvant treatment? And I'm going back to the histopathology. This was a T4 N2B N0. 9 lymph nodes were positive. There was no extranodal extension, but there were margins were clear. LVI and extensive PN was there. So what are the adjuvant treatment? So I may ask our or Dr. Lucy, anybody there?
Arvind sir, you're not audible properly, sir. I think your network is not good.
No, I just wanted to ask a radiation oncologist the adjuvant treatment. Was I clear now?
Sir, Dr. Lucy ma'am was unable to join, sir.
Okay.
Yeah,
Dr. Sheikh is there?
Yeah, Dr. Sheikh is there.
Yeah, Dr. Sheikh, you may take this question.
Sir, you are on mute, sir. Kindly unmute yourself. Sheikh, sir, you are on mute. You are not audible. Anita, can you unmute, sir?
Sir, are you able to unmute yourself, sir? I'm prompting from here as well, sir. I think sir is facing some network issues, I suppose.
Okay. Maybe Dr. Soy, can you take it?
Sir, in this case, we go for the adjuvant chemotherapy definitely. This high risk patients like margin positive or extranodal extension patient, we will go for the both systemic and systemic chemotherapy with radiotherapy. And here we have an intermediate risk group of kind of disease. So we'll go for the adjuvant radiotherapy and may consider weekly cisplatin also in this case.
Oh, great. Any other thoughts? Anybody? Yeah, great points. I think I agree with whatever points you said, but any other thoughts on adjuvant treatment? I think the issue is definitely radiation for sure. Whether to add chemotherapy or not is the larger issue, right? So I think, Dr. Saw, you made your point, high risk versus intermediate risk. Any other thoughts from any other panelists on the adjuvant treatment?
You have more than one lymph node which is positive with extranodal extension.
Right. Correct.
So that itself is an indication for adding chemo to the radiation. So CTRT would be the good way to go about it.
Right. Yeah, I think a couple of interesting points made. I just wanted to sort of inform you all about the results of the OCAT trial. I think this was a trial that the Tatas, and they said that, as Dr. Soy had said, only the cohort of patient with a combination of features, that is, as he said, that margin positivity or extranodal, but seem to sort of benefit much. Although in real world there is an sort of thought to sort of add some sort of chemotherapy based on the factors that Shisha did mention, multiple nodes, PNI, LVI or something. But somehow I think the evidence in real world does not seem to sort of favor that approach. But I again, as I said, there seems to be some sort of a dichotomy between whatever the evidence and real world practice. A lot of institutions and a lot of MDTs and oncologists may actually want to sort of consider chemotherapy, although the evidence per se suggests that purely I think the benefit seems to be in this. Definitely the evidence says that you can consider chemotherapy in other indications as well. I think in the interest of time, I'll just move to the next sort of scenario, very, very common scenario that we see of a young gentleman, PS1. Again, he had a skin involvement, buccal mucosal lesion, and this time he had a PET CT done outside. It showed a low ITF involvement, skin infiltration, masseter space infiltration, but definitely no high ITF involvement. And here is the edema reaching up to the level of the zygoma in this particular patient. And this is a very, very common scenario that we see in real world practice. Fit, young patient, tobacco chewer, extensive disease, left buccal mucosa, skin infiltration, edema up to the zygoma, but no high ITF involvement. Further management, just in the interest of time, I think anybody can take it. Maybe Dr. Gautam, what is your take on it, and subsequently come to the surgical colleagues?
So, since the patient is young and he is having basically edema up to the zygoma, it will be better if we can consider him for 2 to 3 cycles of NICT, then reassess.
Right.
So it is,
any other take? Yeah. You're telling Dr. Gautam, you're telling something.
No, it was basically one of the criteria for borderline resectability.
Yeah. This actually fits into the criteria of borderline resectable. Yeah. I just wanted, Dilip, you had some thoughts. Please share.
Yeah, same thing. If you see the paper of the Dicruz and her, these are the cases borderline. Of course, they are resectable, but not worth resecting. So borderline resectability and neoadjuvant will help in resection, not in OS.
Great. So I think these were the criteria which are laid down. I think does everybody
So Arvind, generally if some patient comes like that, what I generally do is start an antibiotic the moment they come with good mouthwashes and things. Most of us do that. About half of them, all these edema and redness will disappear by the time you decide after the CT, PET, complete evaluation. The redness might go. You realize it's just infection. It's not because of the disease. But point well taken that yes, these are the patients which should go for neoadjuvant chemotherapy. But there are some patients who will just respond. All their redness and edema would disappear by the time you decide in an MDT. What do you do in such a case? Would still give chemo?
No.
But these are lymphatic edemas.
Yes. So you have to differentiate between them.
So those lymphatic edemas may not respond to antibiotics. Those are
Yes.
Sir, I understand, but if it is due to infection, there will be other features of infection also. You have to look for that, like raised TLC, raised CRP will be higher. The skin texture will be slightly reddish. The skin will be the temperature will be elevated. So you have to look after that also. Simply starting
Exactly.
antibiotic not help
No,
exactly.
no, no. So what I'm trying to say is that the moment the patient
Yes,
comes to
yes,
your
sir.
OPD,
Yes,
day
sir.
one of the OPD, this is what we all do. We always
Yes,
start some sort of an antibiotic. We give mouthwashes, we give painkillers,
yes, sir.
and if patient is nutritional correction, nutritional assessment, this is what we generally do. This is the first
Yes,
day
sir.
before you even plan a biopsy. We send the investigations, we plan a biopsy. So you realize that many of the time, all the edema or the infection might go because on the day one you do not know about it. So it's a good practice to do that.
Yes.
Right. Yeah. I think it's an important consideration. Yeah, go ahead, Shishir. Go ahead.
Yeah, that's it. So a point well taken. Just this I wanted to add that sometimes it's very difficult to differentiate between whether it's lymphatic edema or just because of infection.
Right.
So yes, lymphatic edema, you see redness, neoadjuvant chemo is the way to go.
Yeah. I just want to ask Dr. Gautam whether he would use a 2-drug or a 3-drug regimen, or what is it in your practice like?
So, sir, if the patient is fit basically, we will start with the 3-drug basis, no doubt, because the three drug has definitely shown benefit over the 2-drug to the tune of 15%.
So 3 minutes to go, sir.
Yeah, sure. Yeah, I think very recently, I must say that this is the real world data that has come up with the Tatas. I think this is hot of the press publication that has come in oral oncology this month only, about more than 3,200 patients. Most common indication was the indication that we had said, buccal mucosal cancers with edema reaching up to the zygoma, and was rightly said, the 10-year OS was 21% versus 5%. And what was also said in this data is those who underwent surgery, again, 10-year OS of 21% versus 5%. Patients who achieved PCR, again, the survivals was 45% versus 13%. And this is just hot of the press. It's available ahead of print. And this is the real world data. So as was rightly said, some of these indications, I think most people actually prefer the 3-drug. And what about the toxicities, Dr. Gautam? Are you able to manage these toxicities with neoadjuvant chemotherapy in real world practice?
So basically, these drugs have toxicity with a 2-drug and 3-drug. The toxicity with the use of the 3rd drug, the toxicity basically goes up to 2-fold. The main toxicity is basically fluid retention, myelosuppression, mucositis, dyslipidemia. These are manageable, but these patients might have to be admitted and managed basically.
Right. Now, my question to the surgical colleagues, post neoadjuvant chemotherapy, is there any issue? How do you go about the margins and the surgical complications? And this possibly was one of my last questions to the surgical colleagues. Anybody can take it. I think Dr. Sunil, your thought.
Basically, I would prefer a patient who will get operated by the same surgeon because he's the one who has evaluated him. Changing surgeons after showing one surgeon is that difficult because we'll never be able to know the exact extent. Because even after the neoadjuvant chemotherapy, our extent of surgery is not going to change. It will be a compartmental full thickness resection with the ITF clearance. And
I think, Sunil, the larger question is whether it will be the pre-tumor or the post-tumor. That is what we wanted to
It will be based
understand.
on pre-tumor, sir. There's no doubt. Even if the tumor shrinks, we'll have to go by the starting extent only. So NACT in any way does not change the extent of surgery.
Arvind, can I?
Yeah, Dilip, you wanted to. Yeah, please, Dilip.
In this case, right now, if you see the paper of Devendra Chokar, all the resections are post-tumor, post-NACT. So I'll go for post-NACT, and all these patients are going to CTRT. And if you see the paper of Devendra Chokar, none of the 43 patients post-NACT margins, as of margin, not pre-NACT margins, none of them has recurred. So I will go for a present margin.
Great.
And 43 is a very low number, sir, to get to a conclusion.
I agree with you, Sunil. But
I think two contrarian points, and I think it's good to have this contrarian views because the evidence is not clear. In Lisa Licitra's paper, actually, they had used exactly what Dr. Sunil said, pre-NACT margins. But as Dilip said in Dr. Chaukar's paper, they use post-NACT margins. So if you go by the hard evidence, and in both the scenarios, I think the amount of margin positivity rates was slightly lesser, essentially. Again, what has happened is most of the times they leave it to the discretion of the surgeons. But as Dr. Dilip rightly pointed out in the paper by Dr. Chaukar, in the mandibular preservation protocol, of course, that was the NACT was used as a part of the mandibular preservation protocol. It was a phase 2 data. Phase 3 data is ongoing. All the patients actually received adjuvant chemotherapy and radiation. Yeah, sure. I think so that is the larger point I want to make.
Sir.
Yeah. Maybe I'll just finally give the take-home message.
Yes.
Can I?
Yes, sir.
Yes.
Yeah, sure. I think so. I think we had some interesting case scenarios. We did try to glean some sort of information on this. Just wanted to tell that upfront surgery, if it is resectable, of course, and the patient is induction chemotherapy definitely has a role in borderline operable cancers. There is a definition for borderline operable, though not everybody may actually agree with that definition of borderline operable. Some may still want to operate in one out of these conditions. Induction is also having a great role in mandibular preservation, as we had actually discussed. But again, we are awaiting phase 3 data. Again, in the patients who are not fit for either of the approaches, there is some reasonable approach to suggest that concurrent chemotherapy and radiation can be given. Earlier data suggested that we cannot. There is some emerging data to suggest that we can give it as a reasonable option for some of these patients.
Thank you so much, sir.
Thank you, Arvind.
Thank you so much.
Thank you to the panel.
All the panelists.
Thank you all. Thank you, Arvind. Thank you, Cecil. With a short notice, Cecil, you came. Thanks a lot. Thank you
so much, all the panelists. Arvind, sir, it was a wonderful session. Our next session is, so can I begin the next session? Our next session is the debate. It is on anti-EGFR versus IO in head and neck squamous cell carcinoma. I would like to welcome Dr. Padmash Kulkarni, sir, for EGFR. For IO, Dr. Bhavesh Poladia. Padmash Kulkarni, sir, is medical oncologist from Pune. Bhavesh, sir, is medical oncologist from Bangalore. And for the expert opinion, we have Dr. Naresh Somani, sir, from Jaipur.
Good evening, Padma. Straightforward to you. Please make your points in favor of anti-EGFR or cetuximab for that matter, which we are using since last almost 2 decades.
Good evening. Can I have my presentation, please?
And requesting you to please stick to your time.
Yeah, well, I will try to stick to my time. Yeah, so EGFR in HNSCC, can I have next slide, please? As a common man, when we think about EGFR targeted therapies or IO, it used to be like a common man in India looking at a Ferrari or Lamborghini. But now the scenes have changed. Next, we have cetuximab, nimotuzumab, afatinib, and ablotinib as part of component of triple metronomic therapy, as a part of our arsenal targeting the EGFR. Next. 92% of HNSCC overexpress EGFR, and because of the aberrant activation in HNSCC, we can use them as a target using various medications. Next, please. But when we think about PDL1, there are various platforms, different cutoffs, different immunopositivity rates. There is no complete, what we say, we haven't got one value where we stick to when we talk about the PDL1 positivity in HNSCC. Next, please. Bonner et al. Were the first one who used cetuximab concurrently with radiotherapy in hypopharynx, oropharynx, and larynx, stage 3 and stage 4, and showed that it improves the locoregional control as well as overall survival. Next, please. The team from TMH used nimotuzumab concurrently with radiotherapy, and they showed that it improves the progression-free survival by 10% points. The overall survival also improved, but it didn't reach statistical significance. Next, please. IO also has been tried concurrently with radiotherapy. First, priming with concurrent chemoradiotherapy, then continuously as maintenance for 14 courses, 14 cycles. And all of this has improved the event-free survival by 5% point. Next, please. So as we can see, EGFR targeted therapy versus concurrent IO, there is survival benefit when you use cetuximab concurrently. It improves PFS in combination with cisplatin versus single agent cisplatin, as in case of nimotuzumab. And the IO, in spite of 14 maintenance doses, though it improves EFS to a certain extent, it causes significant financial toxicity. Next, please. Coming down to the first line metastatic, the Vermacon et al. Trial using the 5FU platinum, carboplatin with AUC5 cisplatin, and then 5FU with or without cetuximab. They showed that the combination with cetuximab improves the PFS as well as OS significantly with tolerable toxicity. The toxicity is almost similar. Next, please. Then came the next kid, the new kid on the block. The IO pembrolizumab was first one to be compared with the the standard of care at that time in Keynote 40 with methotrexate, docetaxel, or cetuximab. And as we can see, it improves overall survival if the CPS was more than 1 or equal to 1, while it was detrimental if it is less than 1. This must be remembered. Next, please. So next came in the Keynote 48, which studied cetuximab with the extreme protocol, pembrolizumab with chemotherapy, the same arm, chemotherapy arm, which was used in extreme, and then pembrolizumab single agent. Now, of note here, 40% of the patients had a PDL1 of 1 to 19. The 15% had less than 1. So about 55% had less than 20% of PDL1. Next, please. So if we first, let's see cetuximab plus chemo versus IO. IO single agent, that is pembrolizumab versus cetuximab plus chemo. Pembrolizumab is inferior in CPS less than 1%. OS is inferior, it's not equal, it's inferior. And in PDL1, more than 1, less than 20, it is not superior. So as we can see, whatever we are investing in terms of IO, there is no survival benefit for about 55% of patients. Next, please. Now let's consider the combination. You combine chemo plus cetuximab and then compare with IO plus chemotherapy. The overall response rate is same. The toxicity is same. Definitely improved overall survival in CPS more than 20. So yes, I am very much for using IO in CPS more than 20. But if you see CPS 1 to 20, the confidence interval is reaching unity, 0.94. So I'm going to be cautious in that patient because that group, there would be some patients who would be benefited with IO, but
Sorry
in
to
some
interrupt, sir.
others, yeah.
Your 6
Sir,
minutes
the
are
time of
almost over,
6
sir.
minutes. Yeah.
Yeah,
Yes, sir, please finish
yes,
it fastly.
I'm towards the end, yeah. So the OS is similar and similar PFS. Next, please. Afatinib can be used as second-line therapy.
Sir,
As
Dr.
Mr.
Padmas, I'm
Feroz,
sorry to interrupt you. Can we stop the Afatinib and the other EGFR?
Yeah.
I think the theme is to compare the recurrent relapse patient chemo, cetuximab versus IO chemo, if I'm
Yeah.
right.
Yeah, no, I was told about EGFR targeted therapy.
So
Nothing
it's a
special,
6 minutes,
but I'm
6
just
minutes,
done.
sir, please.
I'm done actually. I'm done. There's one more and then last. Thanks. Next. So where I EGFR scores over IO, EGFR targeted therapy is all weather, no biomarker needed, toxicity is similar, efficacy in various treatment settings, available as oral therapy and can be offered to very low income patients also. Next, please. That's it. So it offers various options to a common man, including the high cost original, biosimilar cetuximab and various other therapies. Thank you.
So,
Thank you, sir.
over to you, Dr. Bhavesh, to counter Dr. Padma's points in favor of first-line IO or IO plus chemo in metastatic or relapsed refractory situation.
Thank you.
Please, 6 minutes.
Yes, sir. Thank you, sir. So at the outset, I would like to thank Dr. Ghanshyam Biswas for giving this opportunity, and thank you, Dr. Padmas, to give good points to fight against. So I'll start my presentation. So it will be for IO. So this is what I could understand, that the fight of EGFR versus IO is mainly in the recurrent unresectable in the metastatic setting, both in first as well as second line. And we have two good molecules, pembrolizumab and nivolumab. So I'll also again start with the same design of Keynote 048, which actually in the first line competes pembrolizumab plus or minus chemotherapy versus cetuximab plus chemotherapy. That is the extreme regimen. And this is what is the trial design. And the primary endpoint was OS. This is what we have to take it into consideration. And we see if the intention to treat population, that is a complete population, the green graph is the one which is higher. So that shows that the OS was definitely better. And in IO, what we see is the tail or the long-term survivors. And you can see the tail is much, much higher. Even at the end of 4 years. Hello, can you hear me and see?
Yes, please
Yes,
go
sir,
ahead.
you are.
Okay. So at the end of 4 years and 5 years, the difference is still maintained even at more than 5 to 8%. And the same thing when we see whether it is compared with chemo plus pembro versus extreme, again it is the same thing which is maintained. So you can see the clear difference. The median OS is not something what we have to see when we are comparing pembrolizumab or an IO therapy. So the long-term survivors are better and more. If you split further and you see with the CPS score of 1, so any positivity of CPS, again pembrolizumab alone also scores good, and pembro plus chemo again scores good. Coming to more than 20, there is no doubt there's a huge difference. You can see, you can put one car, one Ferrari, what sir showed in the beginning through this graph. And when we come to the secondary points, that is the ORR, again, when we combine pembro plus chemo versus the extreme regimen, the ORR is not inferior. It is definitely on par. And in fact, there are more survivors. And even the duration of response is much better than extreme regimen alone. Same thing we can see in the same picture, whether it is PDL1, CPS more than or equal to 1 or more than 20%. So I agree that less than 1 or negative is just 15%, as sir has already shown. So it's a very small percentage. 85% of the patient are going to be positive, either one or more. So those are the patients who are always going to get benefited. And we see the treatment related adverse event. So if we use only Pembro alone, where CPS score of more than 20%, it is a very safe regimen compared to extreme. And if we combine both, it is not much, it is not bad. So in conclusion, definitely it is helping. So now we'll see the second one, that's the nivolumab, which is again and used in first line after the patient who has progressed. And these are one of the difficult subset who have progressed within 6 months. So this was nivolumab in full dose every 2 weekly versus investigator's choice. Cetuximab was a part of it. And we can see this is the baseline characteristic well matched. And you can again see the overall survival is in favor of nivolumab versus the standard therapy, which also included cetuximab. Again, with PDL1 status, nivolumab was better. Only in PDL1 less than 1%, it was almost equivalent. So it is definitely not inferior at all. TRAEs, if we can see, in fact, the standard therapy had more toxicity compared to nivolumab alone. So again, nivolumab again as an immunotherapy stands out, and it's always beneficial for head and neck patients. So this is the reason why this is in the preferred regimen and the first line regimen, not even in the first line, but also in the subsequent regimen. So I don't see anywhere cetuximab coming into the preferred regimen according to the latest NCCN. It is in the other recommended regimen, both in first or subsequent line. And not to forget the last few slides on the Dr. Vijay Patil's famous study, that the phase 3 randomized trial using low dose nivolumab plus TMC, that is the TMCI, very simple schema. Using a very low dose nivolumab additional to the triple metronomic chemotherapy, and they showed almost 15% improvement in the response rate. Waterfall plot was very good. That was not the end, but the overall survival also had started improving dramatically from 6 months to 10 months with a hazard ratio of 0.54. And at the end of 1 year, again, I see that median is not something what you have to see. IO comes with a long-term survivors, and IO at 1 year has given 43% versus just 16% of triple metronomic chemotherapy, what sir was suggesting, having an erlotinib anti-EGFR therapy in that. So that is not even half, it is almost 3 times better. And coming to the cost, sir was telling that cetuximab is not costly. I think even with the generic, it is almost equivalent to the innovator. There is hardly any difference between the generic and the innovator, and it is still very costly for the patients who are paying out of pocket. But if you...
Your 6 minutes are up, sir. Sorry to interrupt.
Yeah, this is my
Yes,
last
Dr.
slide.
Bhavesh,
So
please.
this is how the cost benefit is also there. So checklist is complete. It is efficacious, it is safe, and it is cost effective. Thank you.
Thanks, Bhavesh. Back to Dr. Padmaj for 1 minute to make the rebuttal. Dr. Bhavesh, you want to say anything again?
So I think I have put my points. It is definitely efficacious, and it is for almost everybody except for patients who are less than 1%. That is just 15%. 85% are going to be benefited.
Dr. Padmaj, you
cost
want...
effective.
Dr. Padmaj,
I object
Dr.
to this.
Padmaj.
Yeah. Yes. Yeah.
Yes, sir.
I object to this statement that they are helpful for 85%. That's wrong. You have to talk about median, because if you see the confidence interval, it reaches 1 in patients who have a CPS of 1 to 19. So what we need to do is, there's no doubt that IO is helpful. There's no doubt, but it is detrimental for less than 1, and there's probably a percentage of 1 to 19 in whom also it is detrimental. So the cutoff is wrong. Probably we need a better cutoff. It could be maybe 10%, or we don't know, but it needs to be a better cutoff above which the patients are benefiting. The confidence interval is well within the acceptable range and not near unity.
Thanks, Dr. Padmaj.
So just one thing, yeah. I want to just tell, this was a discussion every time that IO are a different type of drugs. So median is not something what we always compare like chemotherapy and IO therapy. So IO therapy, we always see long-term survivors and how many patients are surviving at the end of 2 years, 3 years, 5 years. So definitely all the curves of IO are going to be higher than any chemo or chemo plus cetuximab combination.
The idea is to identify those 20% who are going to be
second and third rebuttals are of no use. The decision is already there. So
okay, so your expert comments.
let me conclude the discussion.
Yes, sir, please.
Both speakers smartly try to deviate from their given topic. Both try to cover the types of the EGFR inhibitor and types of the low dose immunotherapy and the first line immunotherapy. They try to paint the picture like that way, that yes. And Dr. Padmas gave about the relapsed refractory cetuximab plus 5-FU plus cisplatin. So let me repeat, it is the cisplatin and 5-FU with cetuximab versus standard dose pembrolizumab. The inferior overall survival he tried to project in the PDL1 negative and probably of no benefit when the PDL1 is low, less than 20%. And discuss about the PDL1 low, and he said that probably no biomarkers are required when we have to use the cetuximab. Now coming to Bhavesh, he tried to project prominently that there is a plateau or there is a long-term survival of the 20%, which is a big figure. And the trial, the type of the regime, which we often forget, that this trial, the extreme trial, is basically cisplatin 5-FU. Now, if we ask ourselves how many of us are able to use the cisplatin 5-FU along with the pembrolizumab 200 mg. Dr. Bhavesh, I don't agree with you that in this discussion, we can discuss the oral metronomic with low dose immunotherapy. That is not the point, because it is using the afatinib also as the EGFR inhibitor. So we cannot say that it is the methotrexate plus low dose immunotherapy versus the methotrexate. We cannot say that how much the afatinib is contributing it. So what I can understood from this all, that certain patients who are having the very rapid progression, symptomatically clinical crisis, maybe that unselected regime like the chemo plus cetuximab, where you can give even the dosi plus platinum single day regime with cetuximab. If you really want to practice a cisplatin pembrolizumab, then you have to give the 5-FU, which is a continuous infusion for, if I remember correctly, for 5 days.
4 days.
Which probably we are just extrapolating and giving the paclitaxel with the pembrolizumab. So we need to carefully select our patients for both. And I think probably with the cost coming down of the cetuximab in Indian scenario, as Dr. Bhavesh tried to show that the low dose immunotherapy is of the less cost. So maybe the generic cetuximab is somewhere. So probably both types of the regime are going to stay there. That's my message. Back to the organizers, back to the Dr. Ghanshyam. And thanks for this opportunity.
Thank you.
Thank you so much, sir. Thank you so much, all of you. Wonderful session, wonderful debate. So our next session, this is the end of our head and neck session for today. A wonderful overall involvement of all the three branches from surgical, medical, and radiation oncology, and a great session from all the participants, panelists, and our speakers. Thank you so much. Quickly, I'll announce the result of the quiz 1 for head and neck oncology. So for the question 1, Dr. Smriti Mahat is the winner. Question 2, Dr. Varun Sanap. Question 3, Satyendra Kumar. Question 4, Mohammad Wasi. And question 5, Santosh Reddy. These are all the winners for today. I'm sending the list of winners in the chat box also, so that everybody can see. And a big clap to all the winners. Very quick response to all Ghanshyam sir's questions. Thank you so much. Next session for today, now we will start with quiz in gynecological oncology. Ghanshyam sir will start the quiz. Sir, to you.
Thank you, Garima. So good to see Padmaj on the screen. So it's time for another quick quiz before we start the gynec session. So right. So here's the first question. So next slide. So your time starts now. So name the cinestar and her cancer type. So 2018, before COVID, so there were lots of buzz about metastatic cancer, metastatic cancer. You look at the YouTube, you look at Facebook, everywhere. So metastatic cancers, right? So now, so what is that cancer and who is the star? Somebody wrote ovarian, somebody wrote breast. So time's up. So some of you are right. So next, So Sonali Bendre, you know everybody. So she fought actually a metastatic endometrial cancer in 2018, went abroad. So it's Sonali Bendre and endometrial cancer. And a beautiful quote I could find out. What is AC and BC? She also described the two eras of her life. So BC is before cancer and AC is after cancer as difficult phases of her life. So next question. So whoever has answered both Sonali Bendre and endometrial cancer, that's the right. So here's the second question. So according to the Atlas molecular classification of endometrial cancer, so there are 4. So MSI constitutes almost 25%, pole 5%. There are other 2, which is 40% and 30%. So your time starts now. What are the other 2 types? So 4 molecular classifications of endometrial cancers. So MSI pole 25 and 5%. So what are the other 2? 40% and 30%. So we need to have both the answers. Then it will be a right answer. So time's up. So next slide. So you see, so I mentioned pole, which is 5%, MSI 25%, and then it comes to TP53. If it is a mutant, which is a copy number high, constitute 30%, and TP53 wild type, that is copy number low, or which is known as NSMP. So the right answer will be somebody who has written either TP53 mutant and TP53 wild type, or somebody who have written copy number high for 30% and copy number low or NSMP for 40%. So those who have written both these, either mutant and wild type of TP53 or this. So that will be the right answer. So we move to the third question. So again, a question on endometrial cancer. So we know that in a metastatic disease, so maybe we'll be using an hormonal agents at time as a maintenance sort of, or somebody who is not willing for a chemotherapy. So there are a few agents. So one of them, the A, is a magistral acetate at a dosing of 800 milligram, means 160 milligram for 5 tablets. Tamoxifen of 20 milligram. Third is a magistral acetate alternating with tamoxifen. And the fourth, the D, is a anastrozole oblique letrozole. So you have to answer which has the highest response rate, A, B, C, D. Time starts now. So these are hormonal agents used in advanced endometrial cancers. So you have to choose the right answer, which has the highest response rate. So at times, this highest response among these 4 is more than using a chemotherapy. So time's up. So next slide. So somebody who wrote C is right. So magistral acetate 800 milligram has a response rate of 24%. Tamoxifen alone at 10%. But if you are using magistral acetate alternative with tamoxifen 3 weeks on and 3 weeks off for the drug, so 27 to 33%, which is much higher than even using either a combination chemotherapy or a single agent chemotherapy. Whereas anastrozole, letrozole are less than 10%. So that was so. Those who have written C is the right answer. Next, question number 4. So approximately what percentage of high-grade serous ovarian cancers have alterations in the HRR genes? So you have to tell us approximately what percentage of high-grade serous ovarian cancers have alteration in the HRR pathways. So 20%, 30%, 50%, more than 70%. So A, B, C, D. Time starts now. So time's up. So ovarian cancer, unlike any other cancers, so probably that has the highest alterations in the HRR pathways. So probably no other cancer can compete like the HGS. So next slide. So it's approximately 50%. So those who have answered C is the right answer. So approximately 50% of high-grade serous ovarian cancers have alterations in HRR pathways. So that means that these are the patients who will be benefited with the drug like PARP inhibitor. So be it a olaparib or a rucaparib. And we have a session from Dr. Soumya. So choosing wisely also. So now we move to the last question of this webinar series and also for the day 2. So Keynote 158 is a phase 2 study, relates to advanced vulvar cancer, ovary cancer, endometrial cancer, or a cervical cancer. So time starts now. So you have to answer the right. So Keynote 158 is a phase 2 study using Keytruda, the right answer A, B, C, or D. So vulvar, ovarian, endometrial, or cervical. So last 3 seconds. So time's up. And that was the last question. So the correct answer is D, advanced cervical cancer. Next slide. So Keynote 158, phase 2 basket trial. So pembrolizumab monotherapy in an advanced cervical cancer. And all of you know that now PDL1 for a advanced cervical cancer is done free by the company. And now there is an approval for this drug also in cervical cancer. So that was the last question. Next slide. So with that, we finishes the quiz and we'll have the announcement of the results. So before the last session, and now, so with the end, so we'll have a gynec session. So over to Dr. Garima.
Sir, Dr. Garima ma'am is facing a little bit of network issue. Ma'am is rejoining again, sir.
Okay, so next we can start the gynec session. So it will be a talk 5, which is key takeaways in gynecological cancers. ESMO update of 2023 by Dr. Prasad Narayanan. So till the time Dr. Garima joins.
Sir, Dr. Prasad sir has given us the recorded version of the video. I'm sharing the same, sir.
Okay, Dr. Prasad could not join, so he has shared his video. So Anita, please play it.
Yes, sir, I'm doing it.
Good evening. At the outset, I would thank the organizers to give me this opportunity. So in the next 15 minutes, we will discuss about the updates in ESMO 2023 concerning gynecologic cancers. So when we talk about gynecologic cancer updates, usually the first thing which comes or more data will be in ovarian cancer. But surprisingly, when I was doing this update, I realized that the major data or most important data which we will be discussing will be in endometrium and some in cervical cancer. So in endometrial cancer specifically, I think this year has been the year of data which came about immunotherapy in endometrial cancer. So we will see 4 trials, very similar in design and with 4 different immunotherapy drugs with almost similar kind of outcomes, which I think would change the standard of care in endometrial cancer. So this is the first one which I would like to discuss. This is the atezolizumab study. So it was atezolizumab, paclitaxel versus paclitaxel alone, followed by atezo maintenance or placebo till progression. So this is in stage 3 or 4 newly diagnosed or recurrent. Recurrent means 1 line of systemic therapy allowed endometrial cancers. The usual stratification criteria and inclusion criteria here. And there were endpoint assessments hierarchical based on the MMR status. And why this is so, we will know in subsequent slides and also in the design of other studies in the same group. So we had there were equally balanced actually in baseline characters, and most of the patients had stage 4 disease or recurrent disease in 2/3 of these patients. And there were around, I would say around 20, 25, 30% of the patients who had a DMMR status in this group. And let us see the outcome. So this is a remarkable outcome. If you see the all comers, there was an improvement, but the hazard ratios for the improvement in all comers is not as good as what we see in the DMMR group. As expected, the DMMR group, there is a huge difference. It is like the data which we see with sometimes with PARP inhibitors or trastuzumab in HER2 positive breast cancer. So this is an excellent difference. The curves are widely separated here with very good hazard ratios in the PFS. So that was the primary endpoint in this study. The overall survival also, in all comers also there was a slight improvement, which can see the curves are separating, suggestive of benefit of the immunotherapy here. But in the DMMR group, definitely the curves are separating from the beginning itself, with very good improvement in overall survival as well in this group. And if you take the proficient MMR, the other side, I think the curves are not that separate, and maybe there is not much of benefit in the proficient MMR group. So this is the subgroup analysis, and clearly the deficient MMR group is the one which is driving the benefit. You can see that without any doubt there. And even PD-L1 positivity was one factor which actually ensures there is a response to atezolizumab. And as in all immunotherapy studies, the AEs are not much. It is all in the expected lines. And this is across the trials which I will be discussing in this group today. So then the next study which we will discuss today, even more complicated, because here this is the durvalumab with chemo followed by a maintenance of either durvalumab alone or adding an olaparib to the group. So this is even more complicated study. So it's a 3-arms trial, almost similar inclusion criteria. And one inclusion criteria definitely was that the patient should not have got previous PARP inhibitors or immunotherapy, and MMR status should be known. So similar design, but another twist by adding a PARP inhibitor also in the maintenance part. So this is the baseline characteristics. The MMR deficient was seen in around 20% here also. PD-L1 was positive in around 70% of the patients. And HRR also was tested because we have a PARP inhibitor arm in this. So if you take all comers in this study, the intent to treat population, the curves separate definitely by addition of immunotherapy against no immunotherapy. But if you see whether the addition of olaparib has made a difference, there is a difference, but the quantum of difference is not as much as the addition of immunotherapy versus no immunotherapy. So the p-value, if you compare durvalumab plus olaparib maintenance versus control, it is significant there. And if you say only taking durvalumab, there is a difference which is similar to the difference which we saw in the previous study. Also, the subgroup analysis, again, the group which had MMR deficient actually shifted this completely. And HRR mutant patients, as expected, also did well with the addition of durvalumab plus olaparib as compared to durvalumab alone. You can see from this study, from the graph. So if you take the MMR status, no, there is no doubt that MMR deficient patients did really well with the addition of durvalumab, whether or not we gave the olaparib. And the proficient MMR, still there is a difference here, but it is not as profound as the deficient MMR group. The PD-L1 status also separates out the patients here. The PD-L1 negative, the curves are merging in many parts, but the PD-L1 positive group, they start separating from the beginning itself. Overall survival is an immature data. It is only 18 months follow-up here, but there is a suggestion that probably there will be an overall survival improvement which will be significant, which we will see later in this group. So again, that toxicity, it is pretty well tolerated. And this is the third study. This is the pembrolizumab study. This is for 14 additional cycles versus placebo chemotherapy, and again stratified by deficient MMR versus proficient MMR. PD-L1 status also was noted. Again, the percentage of deficient MMR similar here, and the curves, the outcome also similar. PFS is definitely better in the deficient MMR group. In the proficient MMR group also there is a difference, but not as profound as we see in the deficient MMR group. There is a 70% and 46% reduction of disease progression or death in the deficient MMR and proficient MMR group respectively. And the deficient MMR group, we can see the PFS difference. The proficient also MMR group also benefited here. Safety summary, no additional safety summary things which have to be discussed here. Almost similar to the previous slides which I showed you. And these are the AEs in more than 15% of the patients. The last study in the endometrial cancer, this is the dostarlimab study. Dostarlimab with chemotherapy versus placebo followed by maintenance. This is maintenance up to 3 years actually. One was up to progression, one was 14 cycles. This is up to 3 years. And one study had olaparib also in one arm. So similar inclusion criteria, similar data we are seeing, and similar outcomes also. So any form of this immunotherapy with chemotherapy seems to benefit, and specifically in the dMMR group. So overall survival in the overall population also, there is the curves are separating here. But if you take the deficient MMR group, definitely there is a definite improvement which we see. So proficient MMR, for the large part of the first 1 year, the curves are almost together. Safety summary, no major safety summary separately to be discussed here as compared to the previous trials. So now I am ready to give the summary of these 4 studies. The ATISO-2 chemo, definitely there is an improvement in PFS in all comers, but mostly it is attributed to the dMMR group. And despite 41% of the patients crossing over, there was an improvement in overall survival in the dMMR group, which is definitely to be taken. No new safety profiles there. Similarly, if you consider the Durva plus Ola maintenance, there was statistically significant, clinically meaningful improvement in PFS in newly diagnosed patients, and positive trend in overall survival data is also seen. The PFS benefit was seen greatest in the dMMR group, similar to the previous study. And the PD-L1 positive subgroup also benefited. The pembrolizumab study, there was a trend of early benefit during treatment with separation of Kaplan-Meier curves throughout seen in this 14 months of maintenance here, and 14 cycles, and addition of pembrolizumab to standard of care did not increase the side effects here. Also the dostarlimab study, similar report. So the 4 endometrial cancer immunotherapy studies, similar design, similar outcomes. Definitely for deficient MMR, I think we should consider adding an immune checkpoint inhibitor depending upon the availability and feasibility to the ongoing chemotherapy, and patients are likely to do well, and this is the new standard of care in this group of patients. Now, few studies from cervical cancer as well as from ovarian cancer. From cervical cancer, we have this study. This is patients of cervical cancer treated with curative intent CTRT, adding pembrolizumab and maintaining pembrolizumab for 15 cycles after that. 17.9 months median follow-up. This is a phase 3 trial, as we see. Again, PD-L1 status was noted here, and most of the patients in this present era will get IMRT as expected. This is the co-primary endpoint, the PFS. There is a separation, 67.8 versus 57.3. And there is no subgroup which did not benefit with the addition of pembrolizumab here. Overall survival, I think it's too much immature, 18 months of follow-up to discuss overall survival. We may see data separating out, but the curves are almost together here. The duration of response, also we can see that pembrolizumab did better than no pembrolizumab in this group. There are no AEs to be discussed separately. These are all expected lines of in an immunotherapy study. Quality of life was also measured, which was not deteriorated by adding immunotherapy to the chemotherapy arm. This is one trial, I think, which has got some practical implications. This is an induction chemotherapy trial. This looked at they looked at giving 6 weeks of paclitaxel on a weekly basis before the standard therapy and analyze the patients later. So more like a practical, maybe if based on the outcome, a slight practice changing study, and usual demographics and disease characteristics. Most of the patients were beyond stage 2B, stage 3, and some patients of stage 4A, most of them squamous cell carcinomas. And all the patients, 84% completed 6 weekly cycles. At least 5 cycles were given in 92% of the patients. And adherence to radiation also reasonably good, 92 and 97% here. So grade 3A is more in the patients who got the chemotherapy in induction, and alopecia was seen, which is expected with this. There is a difference, the PFS. This is not an immunotherapy or a very expensive treatment here. With 6 weeks of adding, there is an improvement in PFS, which was the co-primary endpoint, which we can see in this curve. Overall survival curves are also slightly separated out, which is something which can be looked at, a 3-year overall survival rate of 88 versus 80%. Patterns of relapse, something which we have to see. The patterns of relapse, the distant relapses were definitely less in the patients who got induction chemotherapy. This is the last study and in cervical cancer. Just to say that these kind of studies are also happening in cervical cancer, where this study is based on patients who progressed on the usual standard, which is chemo plus bevacizumab, to give tisotumab vedotin versus other chemotherapy options. And there seems to be some benefit of giving tisotumab vedotin in this group of patients. In these patients who have progressed on this first-line therapy in metastatic disease, this is a acceptable outcome, with 48.7% of the patients being alive at 1 year with second-line therapy. So anti-tumor activity is also noted with this drug. So this is the summary of the keynote study, the interlay study. The keynote study of adding pembro to chemo radiation could be a potential standard of care. Giving induction chemotherapy is feasible across diverse healthcare settings and can be considered in locally advanced cervical cancer. And the INNOVA study, the tisotumab vedotin, will let us have more and more data coming in with these kind of drugs, where in cervical cancer, which is a major problem in our country. Now, the lastly, we will just discuss one study from ovarian cancer, and this is a study which looked at a biomarker-directed platform. So patients who had 1 to 4 lines of therapy in resistant ovarian cancer were tested for biomarkers and given either cobimetinib or atezo-bev. Just to mention that these are more and more data is coming by using these drugs in ovarian cancer, and ovarian cancer is one crowded place where so many treatment options are there for these patients. So there were responses seen with either cobimetinib or atezo-bev in this study. So that is the only study in ovarian cancer which I have, and that's all in this talk today. Thanks a lot.
Thank you so much, Prashad Narayan sir. Absolutely on time. And shall we move to next session? The next session is on advances in endometrial carcinoma, and our moderator is Dr. Ghanshyam Biswas sir. Sir, thank you so much for last moment again helping us out.
So first of all,
So over to you, sir.
Who is there? So I could see Dr. Kaur, but Dr. Lucy is there. Dr. Lucy, Dr. Manas. I don't see.
Dr. Lucy is not there, sir. Manas sir.
Manas raised hand.
Manas sir is having some network issues, so he's unable to join.
What about Dr. Lucy Patnaik? She's not responding to phone, now WhatsApp.
Yes, sir, we are unable to reach Lucy ma'am as well, sir. Yeah.
Dr. Jyoti Ghosh is there.
So first of all, this is a last moment. So pardon me.
Dr. Manas has joined, sir.
Yeah. Dr. Manas friend dhoka de diya. So just present my slides, no, Anita?
Yes, sir. Yes, sir.
Otherwise, I can do that. Otherwise, I can do that.
Whichever is fine, sir. Yeah. You can also do it, sir. You're also having the access, sir. We have given it. Whichever is convenient, I'll do so.
So I've just prepared a basic slide on endometrial cancer. I think Dr. Prashad talk was great. So since the concerned person could not join, so we have ultimately Dr. Satinder Kaur and Bhagyalakshmi Madam, who are gynec oncologist, and Dr. Joydeep Ghosh, our medical oncology colleague, and Manas Baisar. So we'll try to discuss among four of us. So we'll go to Dr. Satinder. So in terms of incidence, in terms of presentations and imaging, family history, and definitely, are you seeing any change in trend in endometrial cancer? Just brief.
So endometrial cancer is definitely a very common cancer, and it's if we see worldwide, it is the second most common cancer. But if we talk about India, it is still sixth amongst the female cancers. But after cervix, probably endometrium is very important cancer which needs to be discussed. And recently, there has been a lot of changes in its developments in the endometrial cancer, which we have been seeing from staging to advances in treatment with molecular classification coming up. Majority of the patients will be around, if we talk about the presentation, will present with postmenopausal bleeding. That is why, since more than 90% will have this and 90% of the will present in stage 1, there are only less than 10% patients which present in advanced stages of cancer. But that is what it also has a very good prognosis. If we talk about the imaging, the MRI is the best modality because majority of them are in the initial stage. So MRI is usually a best modality to see how much is the myometrial invasion, whether there are any lymph node involvement or not. CT or PET CT is usually recommended if we are suspecting a metastatic disease. But otherwise, a good TVS or just an MRI of the pelvis is a good imaging modality which we need for endometrial cancer.
Right.
Family history is really important, especially if we are suspecting Lynch syndrome, if there is history of endometrial colon cancer and endometriomas in the family, though it is important, it is seen in only less than 10% of the cases. But yes, we need to take majority of endometrial cancers will have specific high risk factors on their own, like diabetes, hypertension, hypothyroidism, obesity. So this is bound to happen. And if we talk about the change in trends, yes, there is a lot of, we are now seeing more and more of patients in the younger age group. Earlier, it was like only less than 5% of patients are less than 40 years of age. But now we are seeing more, maybe it is because of the lifestyle changes, but many younger patients we are seeing with this endometrioid adenocarcinomas.
Right. So absolutely great. So now we go to Dr. Bhagyalakshmi Madam. So first of all, congratulations, Madam. So she had a huge gynec oncology conference in Bhubaneswar where Dr. Satinder was also there. So first, a great congratulations. So Madam, so Dr. Satinder I already touched upon. So I'll just request you. So how different is endometrial cancer from the other gynecological cancers like cervical and ovarian? And second is, have you seen a change in trend, like many infertility patients who are going for infertility treatment? So have you seen the increase in incidence of endometrial cancer?
Yes, Ma'am Shyam. I think I'll touch upon briefly on everything because coming to the presentation, because we are seeing more and more infertility patients during their infertility workup, they are being diagnosed with endometrial cancer, and that's basically without any symptoms at all. So I think with the increasing PCOD, which has become now like a tsunami, so we are bound to get more and more endometrial cancers and women actually delaying pregnancy due to career options. And then coming to changes in trend, I am not sure about what Satinder and all are saying, but now we are seeing actually many high-grade serous clear cell more as 20 years before. Maybe the diagnostic modalities have improved or what has happened, I am not very sure. But initially what we saw as endometrioid, now we are seeing more of clear cells, serous and all those carcinosarcomas, all those varieties more and more now.
Right. So absolutely, thank you, ma'am. So most individuals are diagnosed with an early stage as compared to ovarian and cervical cancers. So if we come to systemic therapy in the medical oncology domain, so historically treatment options have been limited for advanced and recurrent disease. So now let us go to Manas. So staging, there is a change. So general
Yes, sir.
outline of a pathology, or especially histopathology, and any specific test like ISC. So we are not talking about molecular here. Just touch upon.
Yeah. Yeah, like staging, nothing has changed as far as staging is concerned. I think that same endometrial thickness we are giving, whether it is less than 50% and more than 50% kind. And as far as ISC is concerned, I mean, like Madam was telling that subtype of tumor had changed. That is because of maybe we are getting more used to IACs and getting frequently advised, and everything was getting dumped into endometrioid adenocarcinoma. So with use of IAC, we are getting other subtypes of endometrioid, endometrial carcinomas. So, of course, IC has helped.
Right. So now,
apart from diagnostic, also prognostic significance, IAC has got.
Just one word about staging, Dr. Ghanshyam. I think the staging of endometrial cancer has changed drastically in this year itself. But
Absolutely.
But then it's really very, very confusing, and it really takes some time to understand.
The staging, the molecular, and the risk stratification is absolutely, it is a hodgepodge now. It's very difficult.
So, sir, whether it has changed as far as histopathology concerned, or in terms of clinical staging is concerned?
Yes. Now
clinical staging has changed.
Yes,
Not
no, but it's histopathological also, Satinder, because most of them are histopathological outcomes only which are guiding
So
the
staging is histopathological. So definitely it's that as per you, probably the things will remain the same as per the pathologist. Myometrial invasion will be less than 50 or more than 50. But as per the clinicians, the staging has changed
That's what.
on the same
Right.
histopathological basis.
Right, ma'am. Right.
So as Prasad rightly pointed, so in 2023 ESMO, so probably lots of happening endometrial cancer. So last few years it was ovarian cancer, and suddenly there is a shift towards endometrial and also cervical cancer. So I'll just move to Joydeep. So we are talking about early endometrial cancers, locally advanced endometrial cancers. So just tell us about adjuvant chemotherapy or a neoadjuvant chemotherapy. What are the usual chemo cycles and the regimen used?
So we usually follow for adjuvant, especially for the high risk, that is the high risk serology, or if it falls in the high risk criteria as per the FIGO staging, also based on the recent classification, we go for chemotherapy followed by EBRT and 4 cycles of taxane platinum. Although some of the centers, of course, follow the POTEC3 type of regimen where you give CTRT first followed by paclitaxel. That's in early stage, up to stage 3 resected cancers. And for stage 4, where it's unresectable extra-abdominal disease, in those situations, of course, we go for systemic therapy alone. And as such, there is no proven role of NSCT. But yes, in some situations where there is extensive disease and we start with systemic therapy, there is a very good response, which is abdomen restricted. Some of these patients we consider for surgery. So that way it becomes NSCT, but as such, there is no definite role of NSCT in endometrial cancer.
Absolutely. So I think except ovarian cancers, so neither in cervical cancer or endometrial cancers, so there is a definite NSCT at this moment. So since radiation oncology colleague is not there, so any of you can take. So maybe Dr. Satinder or Bhagalakshmi madam. So how has been the conventional role of a radiation oncologist? Just brief anybody.
So basically, the role of radiation actually depends upon what is the final stage. Based on the final stage, the patients is divided into low risk, intermediate risk, high intermediate risk, and high risk categories. Low risk basically involves 1A, grade 1 and 2, with less than 50% myometrial invasion, which will actually not require any kind of radiation. Intermediate risk and high intermediate, that is 1B, grade 1. If we go by the conventional ways, not including the molecular classification, The intermediate risk will like 1B grade 1 and 2, where invasion is more than 50% if it is early grade tumor. And also now as pathologically LVSI has been added. So if there is less extensive LVSI, in that case, there is no substantial LVSI. Intermediate risk, only brachytherapy is required. High intermediate risk also again brachytherapy can be considered if there is no substantial LVSI. But with high risk cases, that is all 1B grade 3 or there is extensive LVSI or stage 2, stage 3 onwards, we need both external RT. And brachytherapy is usually based on the individual's choice based on high risk factors of the vault relapse. And we definitely need to add chemotherapy. Dr. Bhagyalakshmi can add if I have missed upon something.
So thank you, Dr. Satinder. So actually you have just at least helped us in the radiation oncology case. Yes, ma'am, you want to say something?
No, I just wanted to tell that when the uterine cancer goes beyond the uterus, it's similar to a ovarian cancer. Its behavior, everything becomes similar to a ovarian cancer with peritoneal metastasis. So we definitely have a role of neoadjuvant chemotherapy in some situations. So I think we sometimes come across really, really very advanced cases. So there is a definite role. We really do them surgery only after giving them chemotherapy 3 cycles when the disease has become a little operative. And then coming to adjuvant therapy, I think Dr. Satinder has told everything, but with the emerging era of IHCs, so I think there's a little change in the management of adjuvant treatment also. So I think as P53, especially, I think poly may not be available to many centers as of now. But since P53 MMR are available, so our adjuvant treatment will be tailored according to the results of these results as well.
So Joydeep, so what's new about adjuvant in ESMO 2022 and now so many data in 2023? So what's the new about adjuvant therapy? Though you have already touched upon.
So as far as the treatment paradigm shift is concerned, I think there is a significant interest in POL-E positive patients where if it's POL-E up to stage 3, you can actually omit giving any form of adjuvant, and the Kaplan-Meier curves are always straight line in the POL-E group. And of course, that would be an important factor in deciding the adjuvant treatment. As far as newer drugs are concerned, I am not aware of any new therapies which have been tested in the adjuvant window. It's just the standard conventional drugs and
So you are right. So though POL is 5%, and unlike other cancers, so here deficient MMR is much higher. So those POL 5%, you can see all this. So from the Atlas, the Apotek, the grade 3, and many are unselected from 2013 to 2018. So you can see the POL stands up the POL. So POL has the highest, and the lowest has been a P53. And we understand, so P53 mutant or abnormality for across all cancer will remain bad. So if we have selected our patient, as Dr. Joydeep rightly said, even in a stage 3 cancer, so probably, so you just keep them under observation. So that's...
Sir, I have one question for my gyne-onco colleagues. So if it's a low risk TP53 mutant, would you change your treatment plan to adjuvant VVT or anything? Because we face this situation quite often.
Actually, we are looking at two things. Sometimes we request our pathology colleagues also to give us reports pre-operatively from the sample if that's adequate. If not, from the post-operative, actually, if we find a P53 mutant, so we always start with first chemotherapy and then maybe adjuvant radiotherapy later.
But that is also for 1A, madam?
Okay. Maybe then again we will have a little tumor board and decide whether to do or not to do.
So I am not convinced about it, Joydeep. So initially we started doing, and what I have been seeing, I actually did a study on my patients on previous retrospective analysis of around 100 patients, and we did not get even a single P53 positive in that subset of endometrioid. But since the time the staging and everything and classification has changed, I don't know, every patient is coming P53 positive. And so initially we were doing for all. And then as per guidelines, once you have done all the things, you need to suggest them that you need to take chemotherapy. And so now I tell the patient first, if you are prepared to take chemotherapy and radiation, get this test done. Otherwise, don't get them done. Because Personally, I am not convinced in giving
Unfortunately for us,
chemotherapy and radiation for a 1A grade 1 and 2 tumors which has come P53 positive.
Yes,
So
I
I'm really not convinced with this. Probably we need some more data. We have been too quick in changing the staging and treatment guidelines. We
yeah,
need to wait
that
for
would be
some
an
prospective
overkill
results
actually.
for changing all the data as of.
Yeah, then
1A
people are
P53
deciding whether to give or not to give. I think in that places P53 will be helpful. And the number two is that since I am working in a government setup where we have P53 free of cost and wholly free of cost, so it becomes really easy for us to take a call and plan the treatment.
Right. So now Manas, so now the WHO classification. So histology wise, so endometrioid, then serous, then clear cell, and then molecular. So pole versus not pole, then you try to decide. Now the question is that सबसे बड़ा कौन? So is it histology or is it molecular?
I don't know really if you can define in that way. I mean, of course, the traditional way of defining the prognostically bad tumors like clear cell and other things will always be there. But again, the way like other tumors are also changing, like you are going for, since you are having available options for targeted therapy, definitely it should supplement actually, not like which is better or which is I mean lower in yeah, right. So once you are getting the morphology, then you go ahead with the test depending on your targeted options available. So it should
like
supplement
the integration
actually.
of molecular markers, so evidence for their role,
Yeah.
low versus high. Do molecular markers have more impact than histological type, especially in a non-endometrial cancer? And how to integrate LBSI and a sentinel lymph node evaluation? Just touch upon this, no?
So LVSI anyway we were giving it before also now it has changed your staging pattern and your management point of view. But
So how do you
LVSI anyway,
how do you quantify LBSI? So that
usually earlier we were not giving LVSI as the quantification. But we were not quantifying. Now we have to mention it. I mean, number of LVSI that is here.
So right. So this is a ESTRO or the European Society of Pathology group. So you can categorize between low, intermediate, high, and advanced and metastatic. So 1, 2, 3, 4, 5, like the prostate cancer. So next will be a molecular classification and the molecular classification known and unknown. So I'm not going through that. So what is new in adjuvant treatment ESMO guidelines? So all previous guidelines use the traditional well-established clinical pathological risk factors for decision on adjuvant treatment. New guidelines need to address molecular characteristics, molecular classification, other molecular features, relation between traditional molecular and other factors. So what if your center or a country does not have access to molecular testing? So ISC almost everywhere done, targeted, cheap, poll. So what is your take, Jaideep? So suppose, now we need to do at least this. So if poll is not available or the patient cannot afford it, so what is your take on that?
If these are not available, then we would go by the standard way of classifying them into low, intermediate, and high risk group as it was previously, and take a call on the treatment based on that.
Right. So these are ESMO guidelines, so risk groups. So again, so the first thing is adjuvant treatment for a low risk. So I'll start from Dr. Satinder. So low risk by definition by molecular. So what is your adjuvant treatment for this patient?
So the low risk patients actually do not require any adjuvant treatment. For if we go only by the previous classification, stage 1A, grade 1 and 2 endometrioid tumors with no or focal LBSI, as you have said, and all pole mutated stage 1 and 2, they fall into low risk categories.
Right, absolutely.
They do
so
not,
no adjuvant treatment.
Yeah.
So
one thing I would like to add is that in case patient is both P53 and pole positive, like that is the multiple classifiers. In that case, we give preference to pole, not to P53. So they are the pole, or if a patient is MMR positive and P53 also positive, we will consider it as MMR positive rather than P53. Same if patient has both pole and P53 positivity, we will give preference to pole and not give any adjuvant therapy to these patients.
So Jaideep, what about intermediate risk?
Yes, so for intermediate risk, we usually most of the times decide for brachytherapy versus observation. And of course, most of the times for high risk features are there, brachytherapy is an option. But if it is very early, like stage 1A, P53 abnormal, without myometrial invasion, in that case, observation definitely is one of the options.
Right.
But
So again, so age does matter. So maybe somebody
yes,
consider omission, especially if less than 60 years.
yes.
Right.
And I think we should little mention that P53, I think Manas will also agree to me that it is sometimes also very subjective, isn't it?
Yes, ma'am. Actually, there will be lab to lab variations and subjectivity in interpretation also that will be there. So that is again.
I think when we are managing, we have to put everything together and then
yeah, you have to take a call on the morphology and on your clinical judgment as well. So,
like Bhaglakshmi ma'am, so high intermediate risk. So one can be a PN0 after lymph node sampling, and the other will be without a lymph node staging. So what will be your adjuvant treatment?
I think high intermediate risk, according to the previous classification, she will obviously need some kind of adjuvant, especially pelvic EBRT. So they are actually 1A and 1B with substantial LVSI. So I think now LVSI has become center stage of morphological classification in by histopathology. So I think LVSI more than 5. I think that's the classification given by WHO. So less than that,
four or more, ma'am.
Okay, and less than that is focal.
Yeah.
So I think that is very important that all our pathology students should know that they have to report when we are sending a sample. They have to report on all these things. And more than that, if we have a DMMR or NSMP, so in those cases also EBRT is recommended.
Right. So coming to a high risk, Joydeep. So adjuvant treatment plan.
Yes, definitely for high risk, both the modalities should be used, adjuvant radiotherapy, EBRT, followed by chemotherapy.
Right. So, Dr. Satinder, so what about fertility sparing and what are the surgical advances like the robotic? So you just take on that.
So fertility sparing can be done in patients who have stage 1A, no myometrial invasion and grade 1 disease. So these are usually young patients, as we said, because of infertility, increasing infertility, we are getting a higher number of patients with 1A, grade 1 with early endometrial lesions because of they usually have high risk factors like PCOD, diabetes, hypertension, and being evaluated for infertility and found to have early endometrial cancer. So these patients, we can give a fertility sparing, and which we do a hysteroscopic resection of the endometrium and the bit of myometrium also we remove, followed by progesterone therapy, which can be an oral progesterone, which is megestrol acetate in the range of 160 to 320 milligram per day, or we can give medroxyprogesterone acetate, which is around 200 to 400 mg per day, or we can insert a Mirena, which is LNG-IUS. So with this, the patient needs to be very closely followed because these are high dose progesterones and this is not the standard therapy, which the patient has to be explained that fertility sparing is not a standard therapy. But since they are keen for preservation, that's why we are offering them. Every 3 monthly, we have to repeat a hysteroscopy DNC for the patient to prove that it has become negative. Usually the response average comes in around 12 to 15 months. And if the patient is not responding in that time, then she'll need a surgery. And once she has responded, for saying it patient has gone into CR, then at least 2 endometrial biopsies have to be negative. If 2 after 3, which have been done after 3 months, if 2 of them are negative, patient has responded, then patient can go in for her IVF for the fertility or for her conception. She can also try for normal pregnancy, but for a limited period of 6 to 9 months. Talking about the advances in surgery, the main advances is the sentinel lymph node. So it can be done both by robotic as well as by laparoscopic means. And now, especially both for low risk and high risk, we can consider doing sentinel lymph node dissection. For low risk, it has been proven in many phase 3 trials that it is very good to do a sentinel lymph nodes, and we can avoid all the complications of lymph node dissection. As I said, both laparoscopy and robotic are safe in low risk diseases. For high risk, also sentinel lymph nodes and this minimally invasive surgery can be considered in endometrium safely, but it has to be a uterine confined disease.
Right.
If you're doing a laparoscopy or a robotic surgery, you cannot do it for a mental thickening, peritoneal disease, or everything. It has to be a uterine confined disease if you are considering a minimally invasive.
So Manas, we have already touched upon molecular. So what about HER2/neu? How important is in endometrial cancer? Manas?
Yeah, hello. HER2/neu, I mean, is it, it was, is it, I'm also not sure whether you are doing it routinely. I'm not getting, we are not getting too many HER2/neu for the endometrial cancer.
I think that's a new thing now because we have many immunotherapies on that. So HER2/neu is being advised by some of our medical oncology colleagues actually in recurrent settings and all.
Right, man. So I'll just touch upon. So maybe Jaideep will take over. So these are 12 most common disease site. If you look at HER2, so mutations, deletions, amplifications, and multiple alterations. And if you just focus on uterine, so probably the amplification is much more. So these are, we have already discussed about this, the different types of mutations. So high prevalence of somatic mutations in endometrial cancers. So now to Jaideep, sir. Jaideep, so what about HER2/neu and the targeted therapy and hormonal therapy?
Yes, sir. So when we have a metastatic cancer, we usually go for the MMR and the HER2 testing, because these two actually decide the treatment of these two decide the regimen. HER2 more so in a serous, but definitely in endometrioid also you can go for HER2. But it was largely tested in the serous histology in the main registration trial. And if it is HER2 positive, we go for the combination of taxane, platinum, trastuzumab followed by trastuzumab maintenance till progression. And if it is MSI high or a deficient MMR, we recently have the data as shown in my previous speakers where two immunotherapies have shown results. The combination of dostarlimab with paclitaxel and the combination of pembrolizumab with paclitaxel. Dostarlimab has actually shown overall survival benefit. Pembro is yet to show OS benefit. I think the data is immature. And they included proficient MMR patients also. So in the overall population, there was benefit. In the deficient.
Actually, that was a separate question. So I wanted to touch upon hormones and targeted actually.
And yeah.
So how do you find somebody who has exposed to paclitaxel, and then so what about further chemotherapy? And this is the whole list of chemotherapy, either in combination or secondly. So you see, so none of them goes to a double figure. So in that case, probably hormonal therapies for a right candidate, if you can alternate with megestrol, acid, and tamoxifen, so you can get a more response, 3 times response than a chemotherapy. So that was also in the quiz also. So probably there are patients for years together. We have few patients. So probably, so these are poor man's immunotherapeutic agents or a targeted therapy. So they go on well. So this is about the potential targets like the HER2.
1 minute 45 seconds, sir. Sorry to interrupt.
Yeah, Jaideep. So anti-HER2 agents.
Yeah, so of course, HER2 trastuzumab is the most common one that is used, and also newer therapies in the form of HER2 ADCs like deruxtecan, where even if there is a small amount of HER2 positivity, that cohort, the Destiny trial, there is some response. And they're also looking at the TROP2 inhibitors, that is Dato-DX, in the endometrioid cancers. So these are the newer treatments, as Sarah has shown, that deruxtecan, datopotamab, and also sacituzumab govitecan. These are the newer
right
that is coming up.
So Manas, so now, it is getting more importance of getting an HER2 done for endometrial cancer, especially if these patients are not in early stage, because so anti-HER2 space is actually getting therapeutic armamentarium in endometrial cancers too.
Okay.
So
Hopefully,
last 30
I'll
seconds.
get more and more HER2 cases from you then.
Right. So Joydeep, now now there are thoughts, and Prashad presented. So now you can combine IO with bevacizumab or anti-VEGF, or even we have been using pembrolizumab with lenvatinib. So people are now started using in the trial setting those. So IO plus PARP inhibitors, and lots of buzz in this ESMO. So what is your take?
Yes, I think the game has been significantly shifted towards IO, and the standard of care from now onwards would be a combination of IO plus chemotherapy, and not just chemotherapy alone, of course, keeping aside finances. And with the DuoE trial coming into the picture, maintenance therapy with IO, I mean, durvalumab plus parpinib olaparib is going to the way forward. I was slightly surprised why they didn't look at the BRCA positivity in their trial. It's surprising, but yes, at least PARP inhibitors also show improvement in the PFS as a maintenance. Considering bevacizumab in some advanced
So
series,
sorry to interrupt, sir. Time is up.
Yeah, give us 1
for the
minute.
session,
Give us
sir.
1 minute.
yeah, bevacizumab, no, there is a phase 2 study which has shown PFS benefit, but the impact is not as great as an ovarian cancer.
So does it really, besides the classification part and the outcome, so now coming to a therapeutic, so MSS versus MSH, so does it really make a difference in regards to starting of an IO or
Yes,
IO?
definitely. For MSI, MSH, we would be urging more towards combination of IO plus chemo.
Right. So for MSI high, so you can use only IO, but in combinations for anti-VEGF. So endometrial cancer, so probably there is a lying a beauty in future. So key takeaways. So molecular profile must be considered for treatment decision. Targeting different pathways offers a promising strategy to enhance anti-tumor activity. We are at the dawn of personalized medicine in the management of endometrial cancers. I think so. There has been a shift in understanding and the armamentarium for endometrial cancers. So endometrial cancers have relatively high proportions of TMB, high on MSI, high, unlike many other cancers. And there's a rationale for immune checkpoint inhibitors. So the MSI high or deficient MMR phenotype has emerged as a predictive biomarkers. A number of checkpoints, so as you can see, there are 4 drugs that has been approved. Checkpoint inhibitors can be combined with chemotherapy, with the anti-VEGF, and also with the PARP inhibitors. So ESMO guidelines have set a new standard of treatment. Individualized treatment based on molecular risk factor here is to stay, and you can de-escalate. So if somebody is poor or somebody turns out to be a P53, so de-escalation and up the ladder, you can use it. Use of effective targeted treatment therapy based on molecular characteristic. Innovative trials are increasing the select or stratify based on molecular. So immunological factors are important, and the future of endometrial cancer treatment is molecular based. So the primary moderator was absent, so I tried to just whatever knowledge I could get in those small short time I could make it. And I especially thanks Dr. Satinder, Dr. Joydeep, Bhaglakshmi Madam, and Manas for joining us and have such a fruitful discussion. So
Thank you, Ghanshyam.
Thank you, Dr. Ghanshyam.
Thank you, sir. Thank you.
Actually,
Thank you so
endometrium
much,
has
sir.
become
Thank you so much,
central as
Bhaglakshmi ma'am, Satinder ma'am.
Yeah, please go ahead.
A brilliant discussion on endometrial. Ma'am, you're not audible, ma'am.
No, I'm just telling that endometrium
Ma'am,
has
please continue. You were saying something.
Yeah, it has become a Cinderella story. That's what I wanted to say. It's become a Cinderella. The picture which Dr. Ghanshyam showed, someone mopping the floor, to now it has become so important. Initially, everyone thought endometrium was one cancer. Endometrioid, good prognosis. It's a good cancer. So now everything has changed about endometrial cancer. So it becomes Cinderella now.
Correct. And that was beautifully presented by and discussed by all the 4 of you. And Ghanshyam sir, thank you so much for the moderation. Thank you so much, all the panelists. I'll quickly move to the next session. Our next session is everybody's moving towards preventive oncology. So our next session is on cervical cancer vaccine. Is it a hope or a hype? Our expert opinion again is Dr. Satyendra Kaur, ma'am, from Delhi. Dr. Rishi Khandelwal will be speaking for it, and Dr. Stalin Chaudhary Bala will be speaking against it. Dr. Rishi and Dr. Stalin, you are there with us?
Yes.
Yes.
So, over to you. Ma'am, you can take over. Satyendra ma'am.
Yeah, probably first we'll have the discussion. Dr. Richie can present first, and then at the end we'll have the discussion about it. Dr. Richie,
Yes,
please
ma'am.
start your
And
presentation.
ma'am, for speaking for it, you have 6 minutes. You can start.
Yes, I'll just share.
Dr. Karima.
Is my screen visible?
Yeah, it's visible.
Yes.
It's visible, ma'am?
Yeah, it's visible.
Okay.
Can you
So
make it full screen, please?
it's not full screen?
It's not full screen.
No, it's not full screen.
Yeah, that's better.
Good evening, everyone. Myself, Dr. Richi Khandilwal, and the topic for the debate is HPV vaccine hope or hype, and I'll be speaking for the motion. So there's a famous quote by Benjamin Franklin which says an ounce of prevention is worth a pound of cure, and HPV vaccine is cancer prevention. We are taking vaccines for preventing non-cancerous diseases like measles, diphtheria since ages, which also have rare adverse events like this vaccine. So why the hesitation with this particular vaccine, which can prevent as deadly a disease as a cancer? So the magnitude of the problem is huge, as we can see in the world scenario, and 60% of cases are attributed to countries which are yet to introduce the HPV vaccination. The Indian scenario is even dismal, with cervical cancer being the second leading cause of cancer deaths. We contribute 21% of cases worldwide, and 2% of the women are actually screened in our country. So HPV-related cancers, so cervical cancer is just the tip of the, it's just the tip of the iceberg. We have so many different types of cancer, and one single shot of the vaccine can prevent so many different types of cancers. So why not take the shot? So the vaccination can be given from 1 to 3 doses, depending on the different recommendations we have as of now. And 140 countries globally have introduced the vaccination in the national immunization program, and 47 countries are offering male vaccination as well. In 2017, the National Technical Advisory Group recommended inclusion of the vaccine in our universal immunization program too, but it was not accepted at that time due to cost issues. So this is a beautiful graph which is depicting as the HPV vaccination incidence rose, cervical cancer rates had fallen. This is the data from the National Cancer Institute US, and this is the impact which HPV vaccine can have. And HPV vaccines thus are regarded as the single biggest discovery of the 21st century. So HPV vaccination remains the primary screening prevention tool to accelerate cervical cancer elimination as compared to screening and treatment. Real-world data indicates that HPV vaccination cuts cervical cancer cases by 90%. So by focusing only on this deck, we can prevent 90% cases of cervical cancer, as against focusing on secondary and tertiary methods which are not available or available on a limited scale, especially in low to middle income countries. So earlier we were talking about 3 doses, 2 doses. Now there's substantial evidence supporting the benefits of a single dose regime as well, with 98% efficacy demonstrated with a single dose, 30% cost reduction, and 64 million cases of cervical cancer deaths could be averted if we vaccinate more than 90% of females with a single dose at least. This also highlights the concept of herd immunity, which is very strong in the case of this vaccine. So the impact of vaccination, screening, and treatment in 2018, WHO gave a call for elimination of cervical cancer. And if we achieve all the 3 goals by 2030, the mortality will decrease by 98.6% by 2120. But by just reaching 90% vaccination target alone, we can decrease the mortality by about 90% by 2020. So this is the impact. This is a substantial impact which vaccination has. So the immunogenicity data, as we can see, the Cervarix vaccine, the quadrivalent vaccine, and the nonavalent vaccine. For the nonavalent vaccine, we do not have enough data because it was recently introduced in 2014. But for the other two, it shows that the immunogenicity lasts for at least 10 to 15 years. And as time will pass by, we'll have more experience with the vaccine and more data on immunogenicity. There's no known serologic correlate of immunity as of now, and no known minimum titer determined to be protective. So even with the least titers, it is supposed to protect that particular individual. So it is highly immunogenic. This is a cost-effective analysis of the Indian data. This is an Indian study published in the Asia Pacific Journal of Clinical Oncology recently in May 2023, which basically said that HPV is the most cost-effective strategy vaccination to reduce the incidence of cervical cancer and mortality. And on that, the nonavalent vaccine dominated both quadrivalent and bivalent vaccine, indicating that it is the most cost-effective strategy. So it is cost-effective.
1 minute to go, Dr. Rishi.
Yeah. So HPV vaccination not only prevents primary diseases, but also decreases the risk of recurrence after HPV vaccination. We have SIN2+ reduction by 37%, AIN reduction by 56%, and so on and so forth. This is a study published in Vaccines in 2022. So Cervavac is a hope within hope. It is our own indigenous vaccine. It is accessible, affordable, and we have huge manufacturing capability. So hoping to see it soon in our universal immunization program. And these are the safety data sources of HPV. We have official reviews by the WHO Global Advisory Committee. We have post-licensure monitoring, ongoing monitoring by CDC and FDA, which all claim that it is an extremely safe vaccine and it does not contain any live virus. So there's no HPV-related illnesses. Obviously, it has some side effects as compared to like other vaccines. I'm not denying the fact there are serious adverse events also, but the benefits far outweigh the risks. And these are the funding agencies which are actually working globally to fund this vaccine in low to middle income countries. And this is a very interesting study from Sweden, which actually was the first study published in 2022 in New England Journal of Medicine, which is the largest to compare cervical cancer diagnosis among women who did and did not receive an HPV vaccine. It included 1.7 million women, and it showed 90% reduction among women who were vaccinated at a younger age. So this study shows that HPV vaccine is here to stay and will definitely eradicate the HPV virus. So all the major societies all over the world strongly recommend the HPV vaccine, and the ideal age for vaccination for girls and boys is 11 and 12. And so we should not wait and get ourselves vaccinated. Thank you.
Thank you so much. Ma'am, to you.
Yeah, thank you, Dr. Richi, for that excellent presentation. Let's move on to Dr. Stalin, and then we'll have the rebuttal and final conclusion.
Dr. Stalin, slides. Anita, can you put up her slide? Dr. Stalin's slide.
Yeah, visible? My slides?
Yes.
Yes.
Yeah. Thank you for this opportunity. So I'll be speaking against the motion that is cervical cancer is just a hype rather than the hope. So it is tough to talk regarding this because we know majority of the people who are logged in will believe that cervical cancer vaccine will definitely eradicate the cervical cancer. So this is the statistics we all know, and cervical cancer still continues to be a major international public health problem, and international incidences of cervical cancer tend to reflect that in cultural attitudes towards sexual practices and differences in the penetration of mass screening programs. These factors combined with variations in access to effective treatment results in large regional differences. So the majority of what my opponent has shown that the HPV vaccine has significantly reduced the incidence of the cervical cancer, but that majority of the part could be due to the cervical cancer screening programs rather than the HPV vaccination alone, which might have a cause. So you see that the 2003 comparison between the data from the Brazil and United Kingdom showed that similar rates of cervical cancer in young women, suggesting similar levels of exposure to HPV, but rapidly diverging rates in older women, probably because of reflecting the differences in the availability of the mass screening in the two countries. And coming to the HPV and the cervical cancer, we know that the molecular and human epidemiological studies demonstrate a strong relationship, but we know that the 2-valent and the 4-valent vaccines will target only 70 to 80% of the HPV subtypes which cause the vaccine. And we are not acknowledging the 20% of the cervical cancers which are caused by other subtypes, which may be covered in 9-valent because but it is available only over last few months of time. But the 2-valent and the 4-valent vaccines did not significantly contribute to reduction of the cervical cancer in 20% of the patients. And we know that about 90% of the HPV infections clear over time, and of the remaining 10% that persist, 85 to 90% will regress spontaneously. And of the patients who develop CIN3, about 40% will progress to invasive cancer. We also should know that all the trials, trials based upon which these cervical cancer vaccines were approved, so has identified that CIN2, 3 as the primary endpoints, not the cervical cancer. And we know that all the patients who developed CIN3 may not lead to tend to develop cervical cancer. Only 40 to 50% of them will develop the cervical cancer. And we know from the existing data, we are not sure how much with the cervical cancer vaccine, that HPV vaccine, we are able to prevent the cervical cancer. But we know that it may prevent only the CIN2 and 3, but we are not sure how much it may prevent the cervical cancer. We know that there are two strategies of prevention, that is primary prevention and secondary prevention. And my opponent has told that an ounce of prevention is better than a pound of cure. But I believe that prevention should always be secondary prevention rather than the primary prevention, because in a country like India, where the resources are less, the mass screening will probably reduce the cervical cancer incident and save more lives from the cervical cancer rather than from a mass immunization program, which is costlier and may not be cost effective compared to the mass screening programs. And coming to the HPV vaccination and cervical cancer, as I told that there are 3 types of vaccine, the cervical, and from the vaccine studies, especially from the Patricia, it is known that there is a significant reduction in the CIN2 and CIN3, but it comes with certain adverse events of approximately 8 to 10% of in patients. And the results showed that the prophylactic efficacy against the high-grade CIN, that is CIN2 and 3, was high. But in both the trials, it is only in the per protocol and naive cohorts, and it is low in the intention to treat population. In the intention to treat population, the prophylactic efficacy with these HPV vaccinations is only 45%. And although efficacy figures were impressive highly in the treatment total vaccination naive cohorts, it is highly unlikely that either vaccine will show comparable long-term efficacy if used in preteen or adolescent mass vaccination campaigns. This is because we know that HPV 16 and 18 are more often present in CIN3 lesions that appear relatively early after incident infection, whereas CIN3 caused by non-HPV vaccine subtypes generally appear later and so are less likely to contribute to this endpoint in a 4-year trial. And the important considerations were robust data from several population-based cancers shows that the incidence of cervical cancer has been gradually decreasing in both urban and rural India over the past 2 to 3 decades in the absence of either screening or vaccination. Even without proper vaccination program also, we know that the cervical cancer incidence is slowly coming down. Before the 2 decades, cervical cancer was the most common disease in the females, and now the breast cancer has overtook it, and cervical cancer incidence is significantly decreasing due to various other reasons. And another important consideration is that the studies in question has taken the development of either CIN2, 3 as their endpoints,
1 minute to go, Dr.
sample
Sally.
size and trial duration would be more impractical. So both trials have shown maximum prophylactic efficacy in preventing the premalignant lesions, but in only the per protocol population, but not in the intention to treat population. And other serious considerations were the side effects. Coming to the cost effectiveness in low resource countries like India, it is not only the cost of the vaccine, but the costs incurred in setting up a vaccination program, like feasibility, affordability, and logistics of the vaccine delivery must also be considered. And another consideration is the mandated need for ongoing post-vaccine cervical cancer screening. So this vaccination, it doesn't eradicate the screening for the cervical cancer. And apart from the cost of the vaccination, the cost of the screening program also will add on. So it is
Time is up,
to
doctor.
support channeling
Sorry
funds
to
in
interrupt.
mass immunization, and these are the small. Just I will take 30 seconds. And this the benefits and harms. We know that the HPV vaccines increase serious nervous system disorders, which is highly significant. And these are the various unaddressed concerns that there is no data in the literature to suggest the vaccination can replace cervical cancer vaccination. And cost-effectiveness analysis has shown that cervical cancer screening is more cost-effective than vaccination alone or vaccination with screening. And the serious concerns are the cost of vaccination and economic burden to the country like India, mandatory need of screening even in the recipients, and adverse events associated with the vaccination. So finally, my take, cervical cancer remains a major health burden in low to middle income countries, and these are the very nations from whom integration of HPV vaccination into national health program would be an efficaciously very low and costly solution for an already deficient and burdened health system. And the need of the hour remains strengthening of the cervical cancer screening programs, along with further studies to ascertain the efficacy of the HPV vaccination in reducing the incidence of invasive cervical cancers. Thank you.
Thank you, Dr.
Thank you so
Stalin.
much,
It was actually
ma'am.
a wonderful presentation, especially for all those. Yes, you are absolutely right that the majority of us are in favor of HPV vaccine, and we are going to say it as a hope. But anyways, Dr. Richie, would you like to say something in rebuttal? Your
Yes, ma'am. Respected opponent mentioned that screening has led to decrease in incidence, but there was a study published in 2019 by Dr. Harper, and the population was basically based out of Finland. And what they observed that women who were just screened and not vaccinated, because vaccination was not there at that time, the incidence of pre-invasive and cervical cancer was approximately 1.3%. And thereafter, when they introduced vaccination, and population was just vaccinated and those were particularly not screened, the incidence of cervical cancer or pre-cancer in the next 10 years was 0%. And secondly, as he mentioned that screening is not at all cost effective, but there are multiple studies which have actually proven that vaccination is the most cost effective method, especially for a country like ours, because screening and treatment requires immense resources, proper training of doctors, and radiotherapy machines, and etc. etc. So vaccination is definitely cost effective. And the third point which he mentioned is that the incidence of cervical cancer has decreased without vaccination or screening. Yes, the incidence is decreasing. It is basically due to poor, better hygiene which is being maintained, and more awareness on the part of citizens. And secondly, there's a concept of herd immunity, which because of the vaccine there is herd immunity, and that is why also cervical cancer incidence has decreased. And breast cancer incidence has basically increased. It's not that cervical cancer has decreased, so breast cancer has increased. Breast cancer in itself has increased because of lifestyle changes and other issues. And cervical cancer incidence has decreased, but not very steeply.
Yeah, thank you, Dr. Richie. So I'd like to take up on that. I think coming to your first point that the cervical cancer incidence is decreasing in lower income countries, and probably we do not agree it is because of screening or vaccination. It is because of the more number of hysterectomies which are being done, which we probably all think. Then coming to screening, yes, it is a must, and definitely I agree with Dr. Stalin that this is the primary requirement. Screening is must, and majority of the countries, the incidence has come down because of screening. But somehow in our country, screening has been a big failure. As of now, also, only 2 to 3% of the females are being screened out of the total population, and that is why we have not been able to decrease the incidence of cervical cancer, and still we are getting so many advanced stage cancers, and the mortality rate is still so high. So vaccination is definitely a hope, and if we see about the setup required for screening, we need a lot of pathologists, trained people. Even
The
if
time is up. Sorry to interrupt.
yeah, just a minute. So screening and vaccination both require equal cost. Cost is not a problem for Indian population, and now with the Server Act coming up, which has got very less cost. In fact, it is costing around only 1,500 in the general population. I think majority of the Indians can afford the vaccine, and vaccination is a must. And I would say both screening and vaccination are important and they go hand in hand. But since screening has been a big failure for us, so we should actually go for vaccination for all patients. Thank you.
And cervical cancer rates have really gone up according to the last Globocan data in India. That's not gone up.
Yes, correct, ma'am. Correct. That was one point that was not mentioned. Actually, the last Globocan data, cervical cancer is increased in India. Thank you so much. Excellent debate. Difficult to talk against the vaccine. So, Dr. Satyendra did a good job. Dr. Stalin, thank you so much. The panelists, thank you so much for your expert opinions. And Dr. Satyendra, ma'am. So the next talk, I'll go to the next talk for today. Thank you so much, Dr. Rishi. Very well presented. I'll go to the next talk. The next talk today is about rare gynecological cancers case-based study by Dr. Usha Sri Das. Ma'am, I request you to please be on time. Over to you, ma'am. Are you there? Dr. Usha Sri, madam? She's a gynecological oncologist from Bhubaneswar, Odisha. Welcome, ma'am. Over to you, ma'am. Kindly try to be on time, ma'am. Thank you.
Yeah, I'll try that. So good evening, everyone. I thank the organizing committee for giving me this opportunity. I'm going to present two gynec-onco cases of rare histologies. My first case is a 77-year-old lady, para 2, with no family history of malignancy. She presented to us with complaints of lump in lower abdomen since last 15 days and dull aching pain in lower abdomen since last 20 days. She came to us with CT thorax abdomen pelvis done outside, which showed a 9 into 9 into 8.5 centimeter right TO mass with thick wall, fat density in the center with interspersed solid areas. There was no calcification inside. In addition to this finding, she had mild ascites. Apart from that, there was no other suspicious lesion anywhere. No lymphadenopathy. Rest of the abdomen and thorax was normal. In a tumor markers, she had CA of 76 nanogram, CA 19.9 was 5,700, CA 125 was 181. Her upper and low GI scopies were normal. On examination, the positive findings were she had a 20 to 20 centimeter abdominopelvic mass with restricted mobility. The lower border of the mass was not raised, and on bimanual pelvic and rectal examination, POD was free. With this, we planned for staging laparotomy. Total hysterectomy, bilateral adnexectomy, infracoelicometectomy was done. Along with that, bladder peritoneectomy and sigmoid and cecal deposit excision was done with complete gross cytoreduction. Intraoperative findings were as follows. She had minimal free fluid of about 200 ml, a 10 into 10 centimeter mass arising from the right ovary with twisted pedicle. There were extensive adhesion to small bowel, sigmoid, and bladder, and there were deposits over sigmoid, cecum, and bladder peritoneum. Rest of the parietal peritoneum moment of everything was normal. On frozen section, the mass showed mature cartilage, hair shafts, and stratified squamous epithelium with sheets of atypical cells, suggestive of malignant transformation in a teratoma. Her final histopath report showed a 12 into 8 centimeter right ovarian tumor, which showed a squamous cell carcinoma arising in a background of teratoma. In addition, certain tumor areas showed sarcomatous differentiation. Left ovary and both fallopian tubes were free of tumor, omentum was free, and the deposits that were removed from bladder, peritoneum, cecum, and sigmoid colon, they showed similar histology, tumor deposits of similar histology. Immunochemistry, IHC wise, vimentin was diffusely positive, P63, AE1, AE3 was focally positive, Desmin, WT1, SMA were negative. So the impression was squamous cell carcinoma with sarcomatous differentiation arising in a background of teratoma of right ovary stage 2B. At least stage 2B, because lymph node dissection was not done, so at least stage 2B. In adjuvant therapy, she was fit for only single agent carboplatin AUC5 because of old age and frail condition. So she received 6 cycles of single agent carboplatin. Last dose was received on 20th January 2022, but after 2 months of treatment-free interval, she presented again with vague pain abdomen. Her CT thorax abdomen pelvis showed diffuse peritoneal deposit all over her abdomen. And this time she was not fit for any kind of curative treatment. So only supportive care was given with guarded prognosis explained. And 2 months after this presentation, she died. Coming to discussion, the common ovarian germ cell tumors are mature teratoma, dysgerminoma, yolk sac tumor, immature teratoma, etc. Somatic neoplasm arising from teratoma comprise only of 0.17 to 2% of all germ cell tumors. The most common histology is squamous cell carcinoma, that is about 75 to 80% of all somatic malignant transformation of teratoma. The second most common is adenocarcinoma, and rarely sarcoma, melanoma, and small cell carcinomas are also seen. The most common age of presentation is about 50 to 60 years, that is postmenopausal age, and the prognosis depends on stage of the disease at presentation, histology, grade of disease, residual disease after surgery, and what kind of adjuvant therapy the patient receives. Usually, these tumors are discovered incidentally on routine physical examination or imaging for some other reason. And if the patients are symptomatic, it is mostly some vague pain abdomen or abdominal mass. Most common stage of presentation is stage 1, and imaging is also equally non-specific. Like if the most common imaging that we do for early stage ovarian tumor is contrast enhanced MRI pelvis abdomen, it will show contrast enhancement of the solid component inside a cyst with thickening of cyst wall, in addition to the typical features of teratoma like presence of fat fluid component, or calcification, or presence of hair shafts. So how do we suspect that a mature teratoma has undergone malignant transformation? Age more than 40 years, we suspect that most probably she has some malignant component inside the teratoma. If the size is more than 10 centimeter, if imaging is showing something abnormal like thickening of the cyst wall, papillary or solid component with irregular invasion of the solid component, if there is a necrotic component inside, and obviously if there is any metastasis inside abdomen or outside abdomen. In addition to that, if there is increased tumor markers, especially SCC, CA125, CA or CA19.9, then we'll suspect that the teratoma might have undergone a malignant transformation. For management, because of its rarity, there is no definite management guideline. But the usually accepted regimen is primary cytoreductive surgery along with adjuvant chemotherapy like any other ovarian tumor. Fertility sparing surgery can be prescribed in very early stages like stage 1A disease if the patient is very keen on fertility preservation. And pelvic and parotid lymph node dissection is controversial because the tumor spreads mainly by direct extension of peritoneal seedling, but we have to remove the enlarged or suspicious nodes. In adjuvant therapy, the most common chemotherapy regimen that we use is carboplatin paclitaxel. And efficacy of radiotherapy is unproven, mostly reserved for recurrent or for symptom relief, recurrent cases of symptom relief. Coming to my second case, this case is a 43-year-old female, postmenopausal since 4 years. She is para 3, live 3. Last childbirth was 18 years back. She is not ligated. She is hypothyroid. Her paternal grandfather had oral cancer, very tobacco related, with chief complaints of, she presented to us with chief complaints of on and off dull aching pain in lower abdomen since 1 year and wide discharge PV since 1 year. There was no associated bleeding PV for her. She also came to us with ultrasound and CCT done outside. Her ultrasound abdomen pelvis showed a 7 into 8 into 5 centimeter a vascular mass inside uterine body infiltrating the myometrium. The upper part of cervix is involved and lower part of the cervix was spared. Both ovaries were normal. CT scan also showed the similar findings. Except for that uterine mass, there was no other disease outside uterus, no lymphadenopathy, no ascites. The positive findings on examination were the cervix was grossly normal, uterus was bulky, 8-week size, there was ballooning of the cervix, left fornix was tethered, left parametrium was medially involved, right parametrium was free. On endometrial biopsy, it was reported as high-grade carcinoma with squamous differentiation. IHC was positive for P40, AE1, AE3, EMA. Few cells are positive for P63, P53 wild type, whereas vimentin, napsin P16 negative. Provisional diagnosis was locally advanced high-grade endometrial carcinoma. With this, we gave her 3 cycles of neoadjuvant chemotherapy with paclitaxel and carboplatin. Post-chemotherapy, post 3 cycles of chemotherapy, there was partial response on imaging and on clinical examination. Only from 7 centimeter, it maybe came down to 6 centimeter. So we planned a radical hysterectomy. We did type C1 radical hysterectomy and bilateral anisectomy. Intra findings were uterus was 6-week size, tumor was seen protruding from the previous LACA scar. There was direct extension of the tumor into left parametrium. Right parametrium was free. Bilateral adnexa was normal. Rest of the peritoneal surfaces were grossly normal, and there was no palpable lymphadenopathy. Final histopath report showed epithelial trophoblastic tumor of size 6.5 into 4 into 2 centimeter with marked nuclear atypia. The tumor epicenter was in the endometrium, invading myometrium. Lower uterine segment and cervical stroma was involved by tumor. Bilateral parametrium were microscopically involved. Bilateral adnexa were free and LVSI was absent.
5 minutes to go.
Yes, immunohistochemistry wise, the tumor cells were diffusely positive for CK7 GATA3, focally expressing P40, P63, occasionally expressing HPL, and negative for PAX8 and SAL4. Maybe index was 30 to 40%. Post-operatively, her beta ECG was normal, so no adjuvant therapy was given, and she was put on observation. She is doing well to date. Coming to discussion, we all know that PSTT and ETT, placental site trophoblastic tumor and epithelial trophoblastic tumor, are the rarest form of GTN. Both combined, they make up to 1 to 2% of all GTN cases. The cell of origin of ETT is extravillous intermediate trophoblast. The most common age of presentation is between 30 to 35. Most common antecedent pregnancy is full-term pregnancy. That is 65%. The antecedent pregnancy is full-term pregnancy. And the most common clinical presentation is abnormal uterine bleeding remote from a non-molar pregnancy, maybe after 10-12 years of last pregnancy. It is a slow-growing tumor. It can occur months to years after antecedent pregnancy. It lacks specific or sensitive tumor markers. SCG is not an accurate marker of disease burden like in choriocarcinoma, but it is the only tumor marker available. So we use SCG for evaluation during follow-up and to guide our treatment. Imaging is equally non-specific. It presents as an echogenic mass with contrast enhancement. Grossly, the most common site, primary site, is lower uterine segment in 40% of cases, followed by cervix in 31% of cases. Grossly, it looks as a nodular expansile fleshy mass in cervix or lower uterine segment with cystic and hemorrhagic component. In 25 to 35% of cases, it will present with metastasis, usually to lungs. Histologically, it is well circumscribed with expansile growth pattern, in contrast to the PSTT, which has infiltrative growth pattern. IHC-wise, it shows a diffuse expression of P63, cyclin E, and GATA3, and focally positive for MELCAM and HPL, in contrast to PSTT, which is diffusely positive for MELCAM and HPL. The most common, the most proved prognostic factors are time since antecedent pregnancy, more than or less than 4 years, and stage of disease. In some studies, they have also showed that beta ECG levels more than 1000 and high mitotic count may act as prognostic factors. So coming to treatment, stage 1 disease without any risk factors, we can go for simple hysterectomy with bilateral salpingectomy followed by observation. Local tumor excision has been described for women who wish to retain their childbearing capacity. Removal of ovaries is not required in premenopausal cases. Though these tumors, ETT and PSTT, both have a tendency to spread to lymph nodes, there is no therapeutic benefit of routine lymphadenectomy during surgery. For stage 1 disease with high risk factors like high mitotic index, antecedent pregnancy more than 4 years, LVA site, deep myometrial invasion, and persistent elevated SCG levels after surgery, we advise adjuvant chemotherapy. Adjuvant chemotherapy in the form of MACO or MAEP. In higher stage disease, we can go for upfront surgery followed by adjuvant therapy, but mostly we advise neoadjuvant chemotherapy first in the form of MACO or MAEP, followed by resection of residual disease, and then adjuvant chemotherapy if there is persistent elevation of beta ECG. If followed by surgery, there is normalization of ECG, we can just put the patients on observation and treat the recurrent cases. Thank you.
Thank you so much, ma'am. Well before time. I'm happy with that. And a very informative session. And you almost included all the rare cases that are there and with clinical discussion. Thank you so much. It was a wonderful session.
Thank you.
So I call upon the next session for today, Dr. Soumya Surat Panda sir. Soumya sir, the talk about ovarian cancer, different PARP inhibitors, choose wisely. As Ghanshyam sir was talking and everybody was talking about the molecular changes, sir will talk about the PARP inhibitors choosing. Thank you so much, sir. Over to you.
Thank you, Dr. Garima. So now we have got plethora of options by looking at the PARP inhibitors, and we know that at least in India we have got olaparib and rucaparib. That is very much available with us, and besides that you have got niraparib and veliparib. So these are, and of course, talazoparib is also there. So the ovarian cancer, so it has now we know that it is a kind of a heterogeneous disease. So high grade serous ovarian cancer, at least around 50% of the patients, they will be able to treat them with a targeted therapy. So the most common what we knew earlier was a BRCA1 and a BRCA2. So BRCA1 and BRCA2, besides being acquired by germline, it can be besides being inherited by germline, you can also acquire it somatically. So the BRCA1 and BRCA2, they approximately contribute to approximately around 15% to 20% of the ovarian cancer. And besides that, the other DNA damage repairing pathways are also responsible for the high-grade serous ovarian cancer, and they all lead to a particular scar in the gene, which we known as HRD. So the around 50% of ovarian cancer, they will have a homologous recombination deficiency, and the scars will be identified through a next generation gene sequencing. Next slide. So coming to the Indian setting, so we have got data that BRCA mutation testing in germline is around 15%, and extra you can pick up through somatic another 10%. So it is nearly 25%, and the positivity rate in Indian studies is something like 21.3%. When it comes to HRD genomic scar testing, it is around 50%, and HRR gene panel sometimes done can be as high as 30%. So you know that around 25% are having a homologous recombination deficiency, but they are BRCA wild type. So you have got non-BRCA genes responsible for your DNA damage. So HRD is mostly what is now being done. Next slide. So what are the methods to detect the HRD or your DNA damage? One is that you can send a simple blood, look at the germline BRCA. Next, you can do a block and look at the somatic BRCA on that, or what is known as T BRCA. The extra, you can pick up some extra 10%. So germline is 15%. The extra pickup is from the paraffin block is another 10%, 25%. And if you look at the HRD, that is another 25%, that is total of 50%. So that HRD is in the myriad or foundation, the HRD positivity was scored when the score was 42. So 42 out of 100 was known as HRD positive. And as we have discussed multiple times, the components of the genomic instability or genomic scars are through the loss of heterozygosity, a telomic allelic imbalance, and a LST or a large scale transition. So these are the parameters by which your HRD is scored. However, in Indian labs that use mostly a MOIDX platform, they use a gene scar score. So gene scar score of 50, more than 50 is told as is considered as positive. So tumor samples that have individual BRCA1-2 mutations or marker of genomic instability are characterized as HRD positivity. Next slide. So a lot of molecules have been approved right now from 2014 to 2023, and most of them are PARIBs. You know that the maintenance of bevacizumab was already there, and besides that, whatever I told you, like say rucaparib, niraparib, or olaparib, they have come from the later lines. Then they have been used in the first line maintenance as of now. And regarding pembrolizumab, it is used only in MSI or a deficient MMR as a tissue agnostic therapy. And hardly very few chemotherapies have come up. It is mostly these PARP inhibitors and the immunotherapy, that is pembrolizumab. So next slide. So maintenance therapy. Maintenance therapy has been established from the GOG 0218 and the ICON 7 that showed the first line bevacizumab as a maintenance therapy. Mostly it is a PFS benefit and not a OS benefit. And the OCEAN study was in a platinum sensitive. Again, showed that you can use it in a platinum sensitive relapse in ovarian cancer, the bevacizumab. So it is a second line maintenance. Then came the later lines PARP inhibitor like the NOVA, the SOLO 2. So these are the later lines of PARP inhibitor, that is niraparib and olaparib. Then the first line germline BRCA came as SOLO 1. Then the prima of niraparib showed the first line maintenance, and Paula 1, which was based on the HRD score, showed that olaparib plus bevacizumab is a good combination. And very importantly, Ariel 3 by that time had shown rucaparib as a good second line maintenance, and then the Athena mono that came out in 2022 showed that rucaparib in first line maintenance is highly efficacious. So you have got multiple PARP inhibitors being approved in the last few years. Next slide. So choosing among them is really tough. So why? Because PARP inhibitors differ in terms of the biochemical property, hence data cannot be extrapolated from one PARP inhibitor to another, and each PARP inhibitor needs to be assessed based on approved indication and data. and so biochemical properties, they do not reflect always the efficacy, and there is no head-to-head comparison between one PARP inhibitor to another PARP inhibitor. So that's why while choosing the drug, it boils down to the side effect profile and the patient's choice and the approved indication or the FDA or the DCGI approval. Next slide. So as you know, so maintenance therapy, when using a PARP inhibitor, it is always given, or the best responses are seen when it is used in the first line. So first line maintenance therapy is without doubt or unambiguous that PARP inhibitor should be used in the first line rather than in the later lines. So right now, first line you have got to be option of bevacizumab maintenance and a plus a olaparib maintenance, or even germline BRCA setting, you can use a olaparib or a rucaparib, and of course niraparib is for all comers. So in second line, again you have got some data to say that you can use a PARP inhibitor rucaparib if you have not used it in a first line, but later lines the PARP inhibitor may not be that efficacious, rather it may sometimes be detrimental as well. So whenever you are using a PARP inhibitor, always use the first line, and the PFS shrinks with time. Next slide. So regarding the maintenance options, when you are using, so you have to be very careful whether you're using a bevacizumab or not. So if you are using a bevacizumab during chemotherapy, then you have got some data to say that if it is a BRCA mutant, and then you can use from rucaparib, or if you are HRD, you have used the testing, then of course you can use a Pavlova like a olaparib plus bevacizumab. And if it's HR proficient, then you can use a bevacizumab mostly, but you have got some data that the PARP inhibitor like rucaparib and niraparib might be useful, but the magnitude of benefit is very less in HR proficient. When you have not used a bevacizumab, in that case setting, if you use a germline BRCA, then you can definitely use a solo one. And if you are HRR or HRD, loss of heterogeneity, then rucaparib can be used. And niraparib, of course, is based on the HRD, that is a primer trial. So based on the use of bevacizumab, you have to decide on the which kind of PARP inhibitor are you using. Next slide. Regarding what is the, if the patient comes and asks a germline BRCA positive or mutated, and then patient asks you, so sir, how long I am going to live? So right now the data is like something, median PFS is almost like touching 4.5 years to 5 years. So the germline BRCA mutant positive patients that do very exceedingly well if the patients are receiving a PARP inhibitor. So you can see the data from rucaparib, from Athena mono, olaparib from solo 1, and olaparib plus bevacizumab from Pavlova 1, and niraparib from Prima, and bevacizumab from GOG0218. So with time it has improved from the bevacizumab to multiple other PARP inhibitors. Now the PFS is almost, the overall survival is almost reaching nearly 5 years. Next slide. So again, the median PFS, if you look at the delta, how much benefit is being given, if it is HRD positive, then it is something like 19.5 months. So, and if it is a BRCA wild type and still HRD positive, then it is 11.5 months. And if it is HRD negative, then it is 0.9 months. And similarly, the Prima also showed the same thing. So from this slide, what we understand, the magnitude of benefit is best if it is a BRCA positive that is leading the HRD positive. But if suppose a BRCA is wild type and still HRD is positive, that is the second subset, the magnitude of benefit is slightly less than the BRCA positive, but the least one is that where the HRD is negative or HRD is unknown. Next slide. So these are the multiple publications that has come out in NEJM of the Pavlova and the Prima and the Velia. Next slide. So the frontline therapy, we have got multiple options now with the solo 1, Prima, and Pavlova, all. So all comers, if the patient is all comer, then that means irrespective of the BRCA status, then you have got the indications that you can give or consider niraparib and a olaparib plus bevacizumab or a rucaparib. Next slide. And of course, Athena mono. Next slide. So Athena mono, if you look in the PFS, which was the primary endpoint, again that is showing that it is very efficacious in patients which are HRD positive. Next slide. Next slide. Yeah, again, the magnitude of benefit is very high if it is HRD positive compared to HRD negative population. So you have got the indication that you can use that, but the magnitude of benefit is very less. Next slide. Yeah, so across the subsets, if you look at the forest plot, so across all the subsets, be it the maximum benefit being seen in the BRCA mutant population. And if you look at the whether the surgeon has done a residual, means it is a partial a R0 or a R1, so it doesn't matter. Even if the residual disease is there, then also the magnitude of benefit is very high. So it is said that PARP inhibitors are cutting more deeper than the scalpel of the surgeon. So even if the residual disease is there in a BRCA mutant population, then the PARP inhibitor will give you a good advantage. Next slide. Next slide. Yeah. So this is again, if you look at the patients where prior bevacizumab was used or not, again, if bevacizumab is used, then definitely again you have got the very high efficacy of the PARP inhibitors. Next slide. Yeah, so again, so the HRD positive, they've got a very high response rate, even if the patient is having a measurable disease after the surgery and CT. Next slide. So this is the OS data. So we always think that the OS is OS is not mature, but already we have already seen maintenance olaparib is providing a clinically meaningful OS benefit, and also the Paula one is showing the same thing. These are the updated data from the ESMO 2022. Next slide. So the result PARP inhibitor maintenance therapy in patient with BRCA mutation. So if you can see that the A is very the hazards ratio across all. If you look at the solo one, the hazard ratio is 0.33, and the prima it is 0.4, and Paula one is 0.3. So the difference is very stark. Next slide. So again, prima and Paula one, they showed that the magnitude of benefit is maximum with the HRD positive subset. Next slide. So whenever possible, in platinum sensitive second line, you have got some data that you can, if you have not missed, if you have missed out using a PARP inhibitor. Suppose a patient has been treated outside and has come to you, patient has already undergone a surgery and a paclicarbo, or say paclicarbo and bev, and has come to you, and patient has not been tested for a germline BRCA, and you have done the testing, then in that setting whether you can use the germline BRCA, because most of the data is for the front line. Yes, answer is there. You can still consider using a PARP inhibitor in the second line. Of course, bevacizumab is already we have discussed from the Oceans trial. Next slide. Next slide. Yeah, so this is what we have discussed already. The bevacizumab in the recurrent from the GOG 20213, Oceans and Aurelia. Aurelia is for platinum resistant population. Next slide. Yeah, this is so that is a valid option. If you have found that patient is a germline BRCA, then it is a valid option to use a PARP inhibitor. Next slide. So platinum sensitive relapse, the magnitude of benefit is still very high if it is germline BRCA positive. Next slide. Yeah, so the toxicity profile, most of the toxicity for the PARP inhibitor is almost like patient will have anemia, myelosuppression, or a GI disturbance and a fatigue. So these are the common side effects across all the three PARP inhibitors. And of course, the life-threatening MDS or the leukemias are very, very less. But yes, you have to discuss with the patients you are considering or adjuvant setting. Next slide.
So 2 minutes to go.
So this is very important. The post PARP inhibitor, since right now we are all using a PARP inhibitor in the front line, then we must all be prepared for a post PARP inhibitor progression. How to manage that? Next slide. So this is very important that if there is a BRCA reversion mutation, then patients will have a recovery resistance. So BRCA gene is important, assessing the BRCA gene mutation, but also BRCA reversion mutation is there or not, you have to check it. If it is there, then patients will most likely have a recovery resistance. Next slide. So these are some few new drugs like mirvetuximab, sorvastatin in platinum-resistant ovarian cancer, patients who are having a high folate receptor alpha expression. Next slide. Again, this is a WEE1 inhibitor. These are all post-PARP inhibitor, and the trials included a patients who were exposed to a PARP inhibitor upfront. So the WEE1 inhibitor, and as I told you, the folate receptor alpha antagonist. So they are all part of the treatment. Next slide. Next slide. So the last slide of my is that you have patients, you have to test for a germline BRCA or the HRD, and if the patient is positive, then you have to give them the option of PARP inhibitor right upfront in the first line. And if patient has not been exposed in the first line and has come to you late in the second line, then you have to use it in the second line. And if you have not used in the second line, then later lines it might not be that beneficial as we have seen in the first line and second line. So you have to use the PARP inhibitor in the upfront setting. Next slide. With that, I conclude my talk. Thank you. I hand it back to Dr. Garima.
Thank you so much, sir. In time and a brilliant informative session. Sir, I think which PARP to use would be the next session that we will discuss later. So, very nice session, sir. Thank you so much. So I'll go to the next session of the day. That is the last session, and a very interesting session because it is a debate again. And the debate is HIPEC is hype, yes or no? So it is hype. That will be spoken by a medical oncologist, Dr. M.V. Chandrakant from Kolkata. It is not a hype, is by Dr. Vandana Jain, gynae oncologist from New Delhi, and giving the lead to Dr. Shishir Sethi sir from Mumbai. He'll be the expert opinion and panelist for this debate session. So 6 minutes for each and then rebuttals. Thank you so much. Shishir sir, you're there?
Yes, you have already become partial by making me as a panelist. You can't make a surgical oncologist a panelist and not defend a surgeon. So over to you. Please, let's
Thank you so
start the
much.
session. We've got two good speakers. So I would like to start the session on HIPAC for yes, Mr. Dr. Chandrakant. Please go ahead. Dr. Chandrakant is, I think, his slides are clear.
Yeah. So thank you, sir, for that introduction, and I would thank organizers for this opportunity. So I will be presenting on HIPEC. As you can see, it's nothing but chemotherapy, but it is heated and it is given inside the tummy and not inside the vein. The route and heating is what that makes the difference, and we're hitting the same platinum that we give IV. So these are my first reactions, like when a medical oncologist is asked to speak on HIPEC, I really expect it to be against it. But when I am asked, it's like our Prime Minister canvassing for Congress. And these were my first reactions when I have to speak for the motion. So, well, what is the rationale? Why do you want to basically do a HIPEC? These are the probable things. The most common reason why a patient with ovarian cancer dies is because of intestinal obstruction, and eradicating peritoneal disease is the limiting factor, is the most important factor. For that, you need optimal cytoreduction, platinum chemo, IP chemo. All these have improved overall survival. HIPEC is nothing but eradicating that intraperitoneal disease, and that is the rationale. And this is the slide, which is important. The moment patient goes into remission, the first progression-free interval decides the overall outcome. So that progression-free interval, the PFS1, is the one that matters, and that results in long-term overall survival. This is the rationale for HIPEC. CRS, when you combine it with HIPEC, they act synergistically. And when you heat chemotherapy, it results in better bioavailability and improves its efficacy. And there is a good preclinical data for its better action. So, well, do we have any evidence, clinical evidence for HIPEC to show some positive signals? Yes, there are more than 2 randomized controlled trials that has addressed HIPEC in the advanced ovarian cancer setting. And in whom do you want to give? In those patients who are newly diagnosed, even in recurrent platinum sensitive setting, you can give at least stable disease after 3 cycles of neoadjuvant chemotherapy with a good performance status, treated with interval cytoreductive surgery with the residual disease of less than 1 and no history of previous malignancies. And this is how you do HIPEC. It's called as an open Colosseum technique, where you give 100 milligram per meter square. The one that you give IV has to be given, it has to be heated to 42 degrees centigrade with a flow of 1 liter per minute, 50% at the start and 25 and 25. And you need to give sodium thiosulfate for renal protection. And when you use the sodium thiosulfate, definitely the renal toxicity reduces. Well, do you have any evidence for improvement in recurrence-free survival? Absolutely. You can see a good hazard ratio of 0.63, adding nearly 3 to 4 months of recurrence-free survival if I just change the route of administration of cisplatin. Do you have evidence for overall survival? Absolutely. This is one of the rare trials where, not adding fancy immunotherapies, not adding fancy oral tablets, but just changing the route of one single injection intraperitoneally, 10-year follow-up has significantly improved overall survival and the magnitude of difference is more than 1 year. So what else you need? Is it too toxic? Absolutely no. In an experienced hand who can use a peritoneal stripping and who has the experience of handling the toxicities, if you use in a clinical trial, definitely there is no difference in toxicity at all. Grade 3 or 4 is not different. And even in the recurrent ovarian cancer setting, if you use it with the thiosulfate infusion, you do not have difference in renal toxicity also. And there is always a criticism that the subsequent therapies are not well used, but these trials have got 10-year follow-up and the subsequent therapies are used at par in both the arms, and this is well balanced. Let's get quickly into the trials. This is the first trial in the first line setting in an EGM, resulted in improved overall survival and recurrence-free survival. This is the study design and 3-cycle NACT and then CRS HIPEC, 3 more cycles, and then PFS and overall survival. And this is the summary. You can see the 5-year overall survival is 12% different. I mean,
So 1 minute to go, sir.
Median overall survival is 12-month difference. And these are the characteristics. And this concludes that HIPEC improves overall survival. And this is the Korean trial. Again, this also shows an improvement in overall survival with a hazard ratio of 0.53. And this is a recurrent platinum-sensitive ovarian cancer. Even here, the endpoints like overall survival, progression-free survival, time to subsequent treatment, all are better. Well, this is probably the important slide that you have to look into. If you look into the delta of benefit with different drugs, first line wave, the hazard ratio is 0.76, 10 months difference. Olaparib, in whatever setting you use, the hazard ratio is not that impressive. The magnitude is less than a year, but if you use HIPEC and you have 10-year follow-up, and the magnitude of difference is 14 months with a hazard ratio of 0.53. And this is the criticism that I use, that just one cisplatin improved overall survival, but maintenance chemotherapy in a meta-analysis has not shown more. So therefore, giving more cisplatin definitely has not. It is something to do with heating and something to do with giving intraperitoneal. So my final words are, there is an unprecedented overall survival benefit of 12 months with 10-year follow-up. It is replicated in 3 randomized trials, manageable toxicity profile, one-time infusion for 90 minutes, no biomarker, no maintenance, no late toxicity, cost-effective, same cisplatin, heat it up and give it IP. That's the way to go. So HIPEC should be the standard of care in all advanced ovarian cancer with interval cytoreductive surgery. Thank you.
Thank you so much, sir. Sir, one small interruption, Shishir sir, for you also. Actually, the topic is HIPEC is hype. And you had to talk for it, sir. So, sir, I think it becomes the debate. It's a debate. So you have spoken for HIPEC, not for HIPEC is hype. So surgical oncologist, gynae oncologist, and the judge also being surgical oncologist. It's all in the favor
I mean,
of HIPEC.
I was supposed to speak for the motion, no?
For the motion means for the topics. The topic was HIPEC is hype.
Oh,
so
okay.
you're supposed to talk against hype.
Oh, okay. Let her present and I will have a rebuttal. That's okay. I will be able to.
अरे तुमको इंग्लिश में बोलना चाहिए था तुम.
सर मुझे फॉर दे दिया सर. हाइपेक के फॉर दे दिया आपने.
So HIPEC is hype. For
अच्छा. मैं सोचा सर आप हाइपेक के लिए बात करो. अभी तो उसी लिए बात किया मैंने. अच्छा सर कोई बात नहीं. उनको प्रेजेंट करने दीजिए. मैं अभी रिबट.
Yeah, so let us build up the hype more.
So
it's all the hype.
Walk over for Dr. Vandana.
Dr. Vandana, thank you so much for joining us.
Done your job, Vandana. Chandrakanta, done your job. Anyway, please go ahead.
Ma'am, you're on mute, ma'am.
Yeah, Dr. Vandana, please unmute yourself. Thank you so much.
Share my screen from your side. It's not getting done.
Is the screen visible, ma'am? I have shared it.
Vandana, ma'am, can you see the screen?
No. Just 1 second. Just 1 minute. Maybe I'll just try sharing from my side.
Sure, ma'am, you can do that.
Yeah. So. It's not, yeah. So am I visible?
Yes.
So yeah, so after a lot of confusion, finally I'll be speaking on the positive role of HIPEC in various settings of ovarian cancer. So Dr. Chandrakant has already spoken on how HIPEC works, and so I won't be repeating and wasting time. I mean, basically, heated chemotherapy is given and circulated in the peritoneal cavity at the temperature ranging from 42 to 43 degrees centigrade. And ideally, a complete cytoreduction is the best scenario. But even tumor residuals up to 2.5 mm, they will benefit with HIPEC. So the mechanism is impairment of DNA repair function and increased apoptosis and activation of heat shock protein. Open is more commonly performed, though in our institute we prefer the closed type of HIPEC, and they have various advantages and disadvantages. Now, the contraindications are inadequate renal function, inability to tolerate cytoreductive surgery, or extensive intra-abdominal adhesions, and bowel resection is not a contraindication. So now first I'll be speaking on the role in the primary debulking surgery. So the rationale is that 70% patients are already in the advanced stage when they are initially diagnosed, and even after surgery, proper optimal cytoreductive surgery to CC0, no gross residual disease, recurrence occurs in around 60% of cases in the peritoneum due to microscopic peritoneal metastases, which are neither eradicated by surgery nor by systemic chemotherapy. So if you do a HIPEC immediately after primary debulking surgery, the tumor burden is at the lowest. There are no adhesions, and the tumor does not have a chance to develop resistance to chemotherapeutic agents. So it is a French multicenter retrospective cohort study of 566 patients by Bacrin et al. And they evaluated the role of HIPEC in advanced EOC. And they found that the OS was 35.4 months and survival at 1, 3, and 5 years was 83%, 47%, and 17%. And PFS was 11.8 months. And they concluded that for advanced EOC, the curative therapeutic approach is combining optimum CRS with HIPEC, and it is associated with long-term survival, even in patients with severe prognosis and in patients with chemo-resistant disease. So there was another systematic review and meta-analysis on the role of HIPEC in primary cytoreductive surgery in upfront setting, published in European Journal of Surgical Oncology. And they included 9 comparative studies and other 28 studies, which examined the role of HIPEC and cytoreductive surgery for primary and recurrent EOCs. And they concluded that HIPEC with CRS and chemotherapy had significantly better 1-year survival compared to CRS and chemotherapy alone, concluding that addition of HIPEC to CRS and chemotherapy improves overall survival for both primary and recurrent EOC. There is another Chinese peritoneal oncology group study which evaluated the role of HIPEC in upfront setting in stage 3 epithelial ovarian cancer. They included 584 patients. 72% underwent primary surgery with HIPEC, and 27 underwent only primary cytoreductive surgery. And the median OS was 49.8 in the HIPEC group and 34 in the no HIPEC group. And 3-year OS was 60.3 in the HIPEC group compared to 49.5% in the no HIPEC group, which was statistically significant. And the severe morbidity and mortality was not different in both the groups. So there are we are awaiting the data is limited for the upfront setting, and there are various randomized trials which are the data is awaited and the results are awaited.
2 minutes to go.
HIPEC trial. And then now coming to the interval debulking setting, this is the largest multi-center open label phase 3 trial by Vendriel et al. Published in New England Journal of Medicine, and it randomly assigned 245 patients who underwent IDS after NACT to HIPEC or no HIPEC. So HIPEC was given with cisplatin, and the primary endpoint was recurrence-free survival. And they found significantly improved PFS and OS in the patients who received HIPEC compared to the patients who did not receive HIPEC. And the morbidity was not different in both the groups.
Then another study by Lee et al., and they studied the HIPEC in IDS, and around 109 patients were 196 patients were included. And compared to the HIPEC group, in the HIPEC group, the PFS was significantly better, 22.9 compared to 14.2 in no HIPEC, and OS was also significantly better with no difference in the complication rate. Then there was a randomized trial which was published by Lim et al. In the role of HIPEC in primary or interval debulking setting. So in the results, the overall PFS and OS was not different in both the groups. However, when the subgroup analysis was done, then in the neoadjuvant setting, in the IDS group, the PFS and OS was significantly better in the HIPEC group compared to no HIPEC group. So this is about the there's another systematic review and meta-analysis on the role of HIPEC in interval debulking setting, and they included around 6 studies with 674 patients, and they concluded that the addition of HIPEC to cytoreductive surgery in the interval debulking setting improves the OS and DFS significantly.
30 seconds.
So NCCN guidelines also suggest that HIPEC should be given in the IDS setting. Then in recurrence, there are various studies, and I would just quote a systematic literature review, including 16 studies, and it shows promising results in recurrent ovarian setting with the HIPEC. Then there is another meta-analysis of 6 randomized controlled trials, and in patients with advanced ovarian cancer in the NACT setting, IDS setting, they found significant PFS and OS benefit, but not in the primary cytoreductive setting or in the recurrent setting.
Ma'am, your time is up, ma'am.
So just
So
one
sorry to interrupt.
randomized study by Spilitois et al., and they also evaluated the role of HIPEC in recurrent setting, and they found that in the group which received HIPEC, the median OS was 26.7 months compared to 13.4 in the no HIPEC group, and the 3-year survival was 75 versus 18%, which was statistically significant. So there are various trials which are ongoing, like the horse trial, which are awaited. The results are awaited, or Chipot trial. So till then, I think in IDS setting, we should consider HIPEC. Thank you.
Thank you so much. Shishir sir, up to you.
Excellent talks by both the speakers. So I think, of course, the vote always, I'm a little biased towards HIPEC.
So there is no space for rebuttal, sir. Like, I spoke for, there's nobody against, like I can just put a few points for against.
Please do that.
So I just take 30 seconds, 1 minute time, sir.
Please,
So whatever trials have been done, they're in very small number of patients. Ovarian cancer is so common. Why didn't you do in large number of patients? Number one. Number two, intraperitoneal chemo has really shown OS benefit, but how often do we do that in clinical practice? That means people are not comfortable doing it. No matter how many meta-analysis you do, it is not easily doable. That is what is a thing. Only clinical trial you can do. And number three, it has shown only benefit in NACT setting, neoadjuvant setting, but not when you do a primary cytoreductive surgery. And BRCA is a subset where there is absolutely no benefit. In fact, it is benefiting against the use of HIPEC. And the question of HRD, BRCA, bevacizumab, all these are not addressed. And when you compare it with the dose-dense regimen, like a weekly Paclitaxel carbo or a weekly Paclitaxel 3-weekly carbo, the intraperitoneal and this came equivalent. So we do not have this comparison with HIPEC. And do we have comparison of HIPEC versus intraperitoneal? We do not have comparison. So we do not know whether heating is beneficial, platinum is beneficial, or whether it is intraperitoneal. So we really don't know. We are just beating around the bush. And, it is very difficult to replicate among all the surgeons how often the surgeons are trained, So, and sodium thiosulfate is not easily available. When you try to get it, how difficult it is. So it's not doable. You may have a lot of evidence. We may keep debating, but it's not replicable in all settings because we have excellent systemic therapy options. Thank you, sir.
Thank you so much. Do I end the topic or do I wait for the response to this?
Say your call, sir.
Yeah. So what, I'll tell you, just a brief history. Some 25 years back, we seen Sugar Baker from the Washington Cancer Center do this surgery, and we were so critical about doing such an extensive surgery. And even in US, people used to criticize him for what he used to do. Now, if we see world over, it has started. So when I first did my thing was in 2008. The patient was in the ICU for 20 days. So what you are saying is right. In one way that it's not easy to replicate, but with good people and the number of cases and training, when
You're
we
not
got an
audible properly, sir.
So when we got an excellent result, you can't get a better disease-free survival than with HIPEC. I would have to agree with you. In a small subset of patients, we'll have to be a little careful. My own aunt is an example of that, where she was BRCA1 and she got liver mets. And but that's a very different subset. We have seen those type of patient and need to understand. But as of now, HIPEC is a great, one of the best things, best results possible. And with number of doctors who are surgeons who are trained and doing it, I think the results and complications and things are going to get better. Having said that, your points are valid. And of course, you need a good setup, training, and results have to be, evaluated elsewhere. With newer olaparib showing great results, that always is a challenge. And it's always the medical oncologist dream that they can have an excellent drug which can cut through the surgeons totally. I have all my friends who tell me that one good drug and we'll get rid of you, Garika. So till then, I think we are still around. Thank you so much. Thank you so much for the lovely talk.
Thank you so much. An excellent session and an excellent rebuttal by Dr. Chandrakant, who was talking for HIPEC earlier.
He's done a good job.
Yes, sir. Very, very nice. Thank you so much, Sashir sir, Vandana ma'am, and Chandrakant sir. So now I will announce the result for quiz 2, the Gynae Onco quiz today. Question 1, Dr. Shivam. Question 2, Dr. Santosh Reddy. Question 3, Dr. Dinesh Kumar. Question 4, Ankita Das, Dr. Ankita Das. And question 5, Dr. Ipshita Mahanti. These are the winners for the Gynae Onco quiz. I'm sending the list in the chat box as well. Congratulations, all the winners. A big round of applause. And a big round of applause to Ghanshyam sir also to pulling up through the quiz and moderation in betweens and making the slides and getting us all together. I must mention that today's session, from the beginning till end, 140 people were constantly there. People were not able to move from the screen after logging in once. Excellent session, sir, and everybody. Thank you so much, everyone. And thank you so much, Ghanshyam sir, for giving me the opportunity. Over to you, sir.
So before we go to a formal thank you, so I just cannot forget to mention. So while these 3 months of this change in dates, and Chandrakant, Soumi will agree, because of festives. So one man, a young man was behind, so he is Sambit Sahu. And he has been there throughout, so he has developed in last 2 years. Unfortunately, this morning at 3 a.m., he lost his mother at 3:15 a.m. in the morning. Still, he could, in spite of losing a parent, so which I have been through for 2 years back, losing both the parents, is such a traumatic. I had also a similar meeting, and that is World DNA Day, and I just passed on my slides to Dr. Soumya, who helped to go through. So that should be a determination. That shows your proficiency. So in spite of losing a near one, so Sambit at least passed on all those efforts and what has been through. So he's a colleague, and you could not. We finished everything in place in spite of so many faculties who have dropped down without informations for various reasons. So I think as a professional, so we should learn from this hero. I can say hero. So because heroes are not only in pictures, not only in a white dress like us. So a common man can be a hero. So let us at least have 30 seconds for Sambit's departed mother, and he has shown a absolutely proficiency in that regards. So thank you for that 30 seconds of silence. So first of all, I thank Dr. Garima, who has been so phenomenal, a young surgical oncologist, and who has been so supportive. And you have really taken pain through. And I thank my colleague Soumya, who has been instrumental and who has been on my side for every scientific meeting. Similar is for Dr. Chandrakant, so he has never denied me for any scientific occasions I have asked. So thank you, Chandrakant. So we'll love to be associated. And also thank to our big brother, surgical oncologist, Dr. Dilip Kar, who has always been supportive in all scientific endeavors. So thank you, Dr. Dilip Kar, who has been the organizing secretary, Soumya for the program director, and scientific chairperson, Dr. Chandrakant for the Day2. So we have come to our 2 days of webinar. So this was the second episode with different diseases. So again, so 3 months from now, so we'll have a date fixed. So we'll do that. So because lots of new learnings are there. And so now I can always thank those few sponsors who has been supportive. So that was Alchem for the debate of anti-EGFR versus IO. And thanks to Glenmark Oncology. So where we talked about CIMB, the Akengio part by Dr. Soumya. And the head and neck locally advanced panel discussion was sponsored by Biocon Oncology. And last, again, Dr. Soumya speaking on PARP inhibitors choosing wisely. So that was supported by Zydus. Last but not the least, so the International Association of Oncology members whom many of you have not seen, starting from the hierarchy, Rudra, then his wife Sonali, and then Anita, Sambit, and there are many others in the technological team. It's like a Bollywood movie or a Hollywood movie. So there are so many forecasts cast behind the scenes we don't know. And I will fail if I don't thank Siddharth Mahanti, my research head at Spurs, so who has been always so much of helpful and supportive. And in spite of his research work, so he devotes time for all my scientific endeavors. And last but not the least, my wife, my kids who are at home, and my parents whom I have lost, so they must be seeing. So I think, so that was a great journey. So till we meet next, so take care, have a blessed weekend, and love you to have the next time. Thank you so much. Over to the backend team.
Thank you, sir. Thanks a lot, sir. Thank you for your constant support and guidance throughout the webinar. Thank you, Garima ma'am. Thank you, Chandrakant sir. Thank you, Vishwas sir, and all the other faculties who has given their time and joining today's and yesterday's session as well. Thanks a lot, sir.
Good night, all of you.
Thank you.